Well, good morning, everybody, and welcome to the 4th Annual International Conference for Humber North Yorkshire Learning Disabilities and Autism Collaborative. This is the third time I've had the privilege of launching this event, and I'm delighted to be here again. It's become pretty much a fixture in our annual calendar. What we're focusing on today's event is improving the health of our population, levelling up through health equalities, early intervention and prevention, but really focusing underneath that in the context of innovation. And let's face it, it's the most challenging time, I guess, across the country for our nation, but equally across the NHS and certainly here in Humber and North Yorkshire. So there's no better time to be focusing in on how we can improve our services and how we go about caring for our patients and our clients and our communities. So it's a tremendous focus today that we have. We want to celebrate today all the great work that's happening across our mental health services, in learning disabilities and in our autism service across the patch. We're going to try and showcase as we go throughout the morning many developments that are going on over the past year and promote as much interactive discussion as we can around that, so we can foster an environment of learning, and hopefully through that learning and through that innovation that can be translated across the whole of our geography. I know that we've also been setting the tone with lots of those innovations nationally and regionally as well. Amazingly, I think we beat this number every year, so I think we're around about 450 attendees for our conference today, from right across the ICS and from other parts of the country, and we're delighted that you're all able to attend. We've also got a pretty stellar cast actually of national speakers from NHSE and the CQC, talking about what's happening nationally and so on. So we're delighted to welcome Tom Cahill and Katie Matthews. I had the privilege of a meeting with them quite recently, regionally, which was very inspiring. So I'm sure you'll enjoy their session. Katie's a lived experienced policy officer and brings real life experience to that conversation, so that will be great. And then after the break, we're going to hear from Professor Sir Michael Marmot, who doesn't really need any introduction, and indeed his work over many years is even more in focus, isn't it, with the challenges in terms of the cost of living crisis and the impact on wider inequalities. And that's a very important focus for us here in Humber and North Yorkshire, and certainly in relation to our mental health and learning disability services. We're then going to have a number of local speakers covering the life course approach, sharing developments, as I said, that are happening in our area around health inequalities, early intervention and prevention. So Michelle Moran, who probably also doesn't need any introduction, is going to chair the first half of the conference, and then Brent Kilmurray will chair the second half until 1 o'clock when we close. And at the end of the conference, we'll be launching our 21-22 annual report, and that'll be digitally available as well. So there'll be an opportunity throughout to submit questions via the Q&A function. Please do that, and we'll screen the questions via the admin team and then publish appropriately. So with that, I'm going to hand over to Michelle. Michelle, to you. Thank you.
Thank you, Stephen. Good morning, everybody, and it is great to be here today. And Stephen said a lot of it already. I have the privilege of chairing the first half of the session anyway, but I will be here for the full session. I'm Chief Executive of Humber Teaching NHS Foundation Trust, but I'm also the mental health representative on our Integrated Care Board, and I do that with a great privilege. But I was up until July the Senior Responsible Officer for the Mental Health and Disability and Autism Collaborative, and Brent has taken on that role for me, which is fantastic. but it's also the 4th time I've chaired this conference, and I think each year it's gone from strength to strength. So please let us have your feedback, and I'm sure you will at the end. But it also is a really great time, not just to celebrate practice, but to look and learn how we can work together collectively as a community. I know it's an international conference. We will have people from around the world. We normally do, which is fantastic. But there is so much experience out there that we can utilise with this conference. And what we try to do is, if we do get things put in the chat box, not just questions but examples, we will collate those and send those out to people. So please do feel, if you want to share practice with us, then that's fine. As always, I will be keeping an eye on the chat box, so please do that. We've already got a couple of pre-submitted questions which we will which I will pose to the right person, but also there's a panel session at the end. I'm not going to go through the bibliography of our eminent guests because they need no introduction. They are in the pack, but it is fantastic that we have got some really great speakers, and what a subject this year around levelling up the health inequality is so important for our populations that we serve, and everybody makes a difference to patients on a day-to-day basis. We always start with a national picture, and then we go into local and more general feedback and work, etc. So no more from me. You haven't come to listen to me. So I'm going to hand over to Chris Dzikiti, who is new, so fantastic, and thank you for coming, but has got a great background, and I'm really interested about the maybe we can chat about the work in India that you did, and the technical support that you gave in India. I think that'll be really helpful. But over to you, Chris. Good morning and welcome.
Michelle, thank you very much for the introduction, and thank you everyone for joining this morning. It is a privilege and an honor to come and speak to you this morning for the next 15 minutes or so to talk about the next national picture from within CQC. Like Michelle said, my name is Chris Dzikiti. I'm the Director of Mental Health. I recently joined CQC about 8 weeks ago, so I'm still in this phase of trying to work around everything around CQC, trying to get to meet colleagues across the country to just find out a bit more about what we can do together in improving the experiences of people who access mental health services, learning disability and autistic people. So I'll start briefly just to give you a brief sort of overview of where we are at in terms of where are we heading from a national picture. And then I'll give you a bit of a summary of some of the work we have been doing to try and understand what's going on within mental health services within England. And hopefully we can then have time for some questions later on today. Next slide, please. So who am I? I'm a mental health nurse by background. I qualified in 1999 in London and have worked in mental health services for the past nearly more than 2 decades now. Done some work here in England, in Africa, in Europe and in Asia, trying to improve mental health services for different people from different backgrounds. In terms of my recent job, I was working with NHS England, looking at workforce transformation. So I'll touch a bit about workforce, the status of our workforce in England as I progress with my presentation, which everyone I think will be fully aware of where we are at in terms of some of those challenges. In terms of my key priorities as I continue in this job, it's again around engaging with systems, engaging with leaders. So today it's a good opportunity for me to engage with colleagues like, for example, Michelle and Tom, whom I've seen so many times since I started. But this gives us an opportunity to engage, also to hear what everyone is doing at a regional level, at a national level, and at a local level. So really looking forward to meeting with you all today. Next slide, please. So just a quick, a summary in terms of our role and purpose. If there are colleagues from international, I hear there's some colleagues from international countries. In terms of CQC, what we do, we are an independent regulator of the health and other social care in England. And our main job really is to make sure we regulate services, to make sure they are safe for people, they're effective, compassionate, high quality care. And we also encourage services to improve as we progress with changing needs of people within England. Following next slide, please. So this is our strategy. from now onwards, what are we working on? What are our key themes for CQC, for Care Quality Commission, people and communities? This is mainly about actually we want to work with people. We want to work with communities. We want to work with people who use services, who access service. We want to improve, the experience of people who use mental health services. But the best way to improve is to get feedback from people who use the services in terms of how they see services as they access those services. Smarter regulation, we want to make sure how we regulate, we want to improve that. We want to make sure our regulation is adding value to what colleagues are doing in terms of providing mental health services. I want to make sure actually we can do it more over a period of time. We can access more services, we can regulate those more services, but making sure actually we're doing it within a short given time so that we can give people more time and feedback that they can use to improve their services. Safety through learning. What are we learning from services? What are some of those issues that people are going through in terms of services, whether they're safe or not? What can we learn from that? How do we share that learning as we go around? Because we've got a great opportunity. We move around different parts of the country. We move around different services. Can we learn from those services and share across the board? And how do we accelerate improvement? When we see great organization doing improvements, how do we accelerate that? How do we support that? And then the last bit, it's really about reducing inequalities. I mean, we know people who access mental health services, some of those inequalities in healthcare. How do we improve? We talk a lot about parity of esteem. How do we make sure that becomes a reality? That actually, as we talk about it, people who access mental health services can look back and say, yes, it's now a reality that we've got parity of esteem. Next slide, please. And it's all about person-centered care. I'm a nurse by background, and I think the whole reason why we do what we do, all of us, why we're on this call, is to make sure actually we are delivering person-centered care. So our strategy really is focusing on people's needs, driven by people's needs, their experiences. So how do we put those experiences into services? When I looked at and I heard what was happening during Panorama about Manchester, you learn from those experiences, isn't it? When I listen to parents, their experiences of services, or patients, their experience of services, how do we use those experiences to enhance what we do as CQC, and how do we use that to inform how we regulate services? And it's really mainly based on I and we statements, because we want to bring people's needs to life, people's experiences to life. If we move into the next slide, please. There is our single assessment framework we will use going forward from a national point of view. There are 5 key questions in that single assessment framework. They are focusing on quality statements because we want to measure quality of care within services. And then we want to use the evidence. What is the evidence? Evidence might be from what we read in people's clinical records. It might be evidence from talking to people, from talking to their families, from talking to leaders, people who are leading services. What has been the experience? And we'll use that evidence to make judgments on whether there's high quality. What's the leadership like? What's the culture like? What's the governance like? But really using people's experiences of using services. Next slide, please. Like I said, the I statements. So this is about someone who uses mental health services. When I move between services, settings, or areas, there's a plan for what happens next and who will do what, and all the practical arrangements are in place. This is about really someone's pathway. When it moves from point A to point B, is that seamless? Do people understand actually the needs? Is there any breakdown of actually people's needs and how they are looked after? And we want to focus and hone in on those I statements. We are looking at we statements. This is really working with people in partnership. So it's working with colleagues, for example, online here, Michelle, yourselves, working with you guys in partnership to really understand, as leaders of organizations and systems, what are some of those challenges? How can we be assured when we monitor those services as we go forward? Next slide, please. So in terms of the national picture, I think this was the main focus of my presentation around some of the issues we picked up from our state of care report around inequalities in care. I think the biggest thing that everyone will agree is workforce shortages, and which remain a greatest challenge across the sector, whether in health, whether in social care. This remains the challenge that everyone is facing. And whether we've got the right staff levels and skill mix, which is actually preventing in people receiving the care and treatment they need. And this is a challenge across the board. And I think we will need to find solutions as we come together to try and find exactly how best we move from these challenges. There's also something around actually staff themselves. When you think about if you've got limited staff, the impact it has on staff. I mean, during the pandemic, we saw the impact of the pandemic on people's health and well-being. And when you've got limited staff, and when you're constantly working without enough staff, that leaves a burden and an impact on how people feel as they work in services. And then it results in unmanaged workloads when people are working long hours, and then the pressure that leaves systems in. Next slide, please. Like I said already, the issue around vacancies, for example, if you look in London, 16% of vacancy rate, and that's just on average. But when you look at different organizations, some organizations are at 30% vacancy rate. People are either retiring or people leaving because of different things, and people are making different choices. This is something we are seeing across the board, that since the pandemic, people are starting to make different choices. When I speak to clinicians, I hear people saying, I've had to reduce my hours because I want to spend time with my family. So people are making those choices that they never used to make before. We did a community mental health survey in 2021. 2 in 5 felt they were definitely seen in the last 12 months. And this is the impact of that shortage of workforce within our community mental health services, that actually only 2 in 5 patients felt they were being seen. Also, in terms of actually where the people recognize people's needs, the previous year we were at 86%, we are now down to 81%, which is the impact again of what we are seeing in terms of the limited workforce we've got. I won't touch much around learning disability because I know Tom will pick on that up. Next slide, please. We also looked at monitoring the Mental Health Act, our report, which we published on the 1st of December, which is now out online if people want to have access to that. And as we were doing that report and talking to people who are using services and talking to leaders within mental health services, there are issues which keep on coming up, that actually mental health services and staff are at breaking point, right, because of the staffing shortages. And this is across the board. I've moved around recently, talking to different leaders, talking to different chief execs, medical directors, chief nurses, and this is one area that people really are worried about. And then it's putting safety because of the risks, increased risk because of violence and aggression on wards because of those limited number of staff. The longer term national workforce planning required to tackle. I think nationally, this is what we keep on. The message we have from CQC is we need to look at longer term national workforce planning to just think about how best do we manage the workforce shortages at this current time, and also thinking about 5 to 10 years. There's something around, Black and some ethnic minority groups, people, the way they experience mental health services around, for example, care and treatment or community treatment orders, that we've seen actually a huge number of people, especially Black men, who have ended up on CTOs for a long time. And we're thinking about how best can that be improved in terms of working with system leaders to think about how do we improve the experience of different ethnic minority groups across England. And I mean, providers are doing a lot to try and meet this challenge. People are trying to find ways to improve how they improve their workforce using different roles to support, workforce within inpatient mental health services. There are big, huge concerns around the experience of children and young people. 30% increase in under 18s in adult wards. I mean, in the last week alone, we had 10 young people in pediatric wards, because we've got a limited capacity in terms of tier 4 CAMHS beds, but not just because we've got a limited capacity, but there are also challenges in terms of our community mental health services, the crisis services. Do we have robust crisis services to support people as they're getting into crisis, to avoid then going to A&E and avoid going back into CAMHS tier 4. Conversations I've been having with police, for example, there are challenges around the Section 136 pathways that actually police, their feedback is they're spending a lot of time with people under Section 136 because they don't know where to take them because of limited capacity. So we are at that point in time that we've got all the challenges we are facing at the moment from a national picture. But what's encouraging is to see providers across the board who are doing all they can to try and address some of those challenges. So Michelle, I'll leave it there unless there are any questions later on But thank you for this opportunity just to give a rough idea and a summary of where we are at in terms of some of the work we're trying to do with a single assessment framework going forward, and thinking about some of the challenges we are seeing around workforce, around access, around some of the challenges people are facing in trying to support people who are either in crisis and needing inpatient mental health services. Thank you very much.
Thank you, Chris, for a really interesting presentation, and I actually obviously support everything you said, because I think access is obviously one of the biggest issues, and obviously that leading to out of area placements, etc., but also the differentials between the ethnic groups is also something that we've been providers and have been looking at for a long time. So it's good to start to share that. I've just got one question. I think we've got time for it, if I may, Chris, because it's specific about what you said in the last couple of slides. Obviously there'll be more for the panel, but and it's a question that's coming around: what sort of best practice have you seen regarding tackling racism in organisations, and is there anything that you can share with the conference?
No, yeah, that's a good question, and I think for me, the organisations I've seen we're trying to do better is people who don't actually avoid talking about it, and I've seen. I was talking to a few gentlemen who are currently in hospital at the moment with mental health needs, and they asked me that question actually about what will CQC doing around the racism, because these are people with mental health needs in mental health hospital. And I was having a conversation with them, and I was just saying to them, what's your experience, of services and how you're being treated? And they told me their stories. Right. And then I said, do you think the organization is doing more to support? And they said, yes, the organization is doing more to support. And I said, what are they doing? And they say they are not afraid to talk about it. They are being brave to talk about racism. So they don't use any other words, because sometimes you read certain reports, they avoid actually mentioning racism. They will talk about people are disadvantaged, people have got these experiences, but actually not actually say the word. It becomes like a taboo. So what these patients were saying to me were like, Chris, actually what's really encouraging is people are not afraid to say racism is here and we need to do something about it. So don't use other words to mean there's racism. Just focus actually on saying it is racism. What are we going to do? So be brave, talk about it, because the more you talk about it, the more people are comfortable to have further conversations about how to improve. And that's one thing I've seen actually will make a big difference when people start talking about things to try and address some of those challenges.
Thanks, Chris. And I mean, it comes back, I mean, what you mentioned Manchester, and I mean, it comes back to the Eden Field piece, but it comes back to that close culture work, doesn't it?
Yeah.
Yeah. If you've got close cultures, then it's about that talking and being honest. And certainly one of the things our organisation are looking at in the new year, big respect campaign, respect for everybody. Yeah. Across the organisation, so it's that cultural piece, isn't it? But we could talk about that further. Maybe there's some more questions on that. That'll be really interesting. I'm going to leave you there, Chris. Thank you so much. We'll come back to questions. We have got a session at the end for panels about 10:20. So thank you very much, Chris. I know we can't give you a round of applause, but I can on behalf of the conference, and we'll come back to you later. So thank you. I'm going to move us on now to Tom Cahill, who doesn't need any introduction. I'm sure a lot of people in the audience know Tom. I've had the privilege of working and knowing Tom for, I'm not going to say how long, Tom. I'll keep that a secret. But no, seriously, and Tom has recently, well, it's not recently, a while ago, taken on board the national lead for, and I'm going to say autism and learning disability, because we've got a question on that later, services. So good morning, Tom. Welcome. Thank you so much for being here, but over to yourself.
Good morning, and 400 people, so welcome everybody. I'm Tom Cahill. I'm a mental health nurse as well, so I'm proud to say that. And until December last year, I was Chief Executive of Hertfordshire Partnership Trust, so everything that Chris was talking about, I could see it from a provider angle. Unfortunately, I had a colleague of mine, Katie Matthews, who was probably the most inspirational speaker of the two of us. So she's not very well, but I'll hopefully I'll do her justice. I'm going to take you through the national picture from Learning Disability. And there's quite a few slides, but I think the slides are there for information, and you can share them afterwards, Michelle. But I'll fly through them pretty quickly. So if colleagues move to the next slide. So how homes, not hospitals. So this is Katie, and I'd just like to park there for a second. Katie's part of our team, and brings a really fascinating experience to us. She's Down syndrome, grew up as a carer, and she really brings a knowledge to us that I could talk about all day, but 5 minutes listening to Katie, really inspirational. She likes to challenge people in the program in different ways. She asks the obvious questions and also the not so obvious questions. She's got personal experience of being a carer. She does want to improve services, and she does improve services. And she always reminds us, focus on our strengths, not on our weaknesses. And maybe that should be a mantra that we need to continue with. Next slide. So everybody knows about learning disability and autism, and the leveling up that Stephen talked about is really important. And what other group that needs leveling up and support? We 1.5 million people with autism, with learning disability in the country, about 700 people to 1 million who are autistic in the country. And our last leader report, which is 2021, 3,000 deaths, some really staggering information. 49% were avoidable causes, and I won't go through them all. What we know during COVID, 2.3% more, 2.3 times more likely to die from COVID than the normal population or the usual population. So really some stark figures. And those of you who have watched Panorama recently, you know, people who went into hospital and didn't get the support they needed, didn't get the reasonable adjustments they needed, and this happens a lot. So a really important agenda here, and it is about people, not services. Next slide. So long-term plan. if I'll take you to the next slide, and if we go to next slide, I'll just give you an idea of our program. So we have 7 key planks of work: improving quality of people in hospital. And I'm very clear there are times when people do need support in hospital, but not to the level we've got. And I'll talk to you a little bit more about that. Reducing the number of people who are in hospital, and I'll talk about that in a moment. Improving the provision of community services. And when I look back, I'm a mental health nurse by background. When I look back at the community development of community mental health services, learning disability and autistic services, support for learning disability and autistic people are a long way behind that. Improving outcomes for children and young people, some really good work there, but more to do. And improving health outcomes and access to care, I think, is the biggest priority of all. If we're really thinking about going forward, this is the biggest priority. Improving outcomes for autistic people in all of these settings. And firstly, in education at home is really important. But Chris talked about the workforce, and we know that's a big challenge for the health and care workforce. So I'll take you through a few of the key elements of the program now, and then just finish on some of the key priorities as I see them. Next slide, please. So quality of care is really important, and you know that we've heard recently, and we're all staggered with some of the information, those findings that we've got of people in hospital who are not getting the right care, they're not getting the right support. We know from our safe and wellbeing reviews that physical health care is a major element of care in hospital for people with learning disability or autistic people. We know about 40% of those we reviewed need support, but not in a hospital setting. So we really need to make sure that we do everything we can to provide those. And then we have a significant number of people who are in long-term segregation. And we have to ask our questions. And if you hear Alexis Quinn speaking, she said she felt like a monster when she was in when she was in segregation. And we have to think about, what can we do? What is the model of care? What more can we do to really improve this? So keeping people well when they're in hospital, short periods of time, really important. Next slide, please. So reducing the number of people in hospital, really important. We've got about 1,800 adults in hospital. And if you think about in the region that we're in, at the moment, 301 in hospital, which needs to reduce to 241. If I tell you that 90 of those have been in hospital more than 10 years, and why are people in hospital more than 10 years? Okay, I understand some of the secure arguments and people in Rampton and Bromo and those, but why so many people for so long? 88 people in between 5 and 10 years. Well, we are seeing some really good successes of helping people get out of hospital after a long period of time. But we do really have to ask ourselves, what is it that's gone wrong and what can we do to change that? Next slide, please. Improving community services is a really important element, and I think it does speak to the issues of why some people are in hospital. What we're seeing is that there isn't a sufficient community provision to help people stay in their lives. And I think staying in their lives is a really important concept here, rather than necessarily staying at home, but staying in their lives, whether it's a short period of time in hospital or whether it's getting community support. We have had £25 million investment the year before, 40 million last year. And I'm hopeful, I'm not quite sure there yet, but I'm hopeful there'll be a significant figure around the 40 million mark for the year ahead. So if we can do that, then you have a real opportunity to build decent services that are sustainable and help people stay in the community. We're also working very closely with LGA and ADAS to make sure that the social care element of this is paramount and a real opportunity for ICSs and ICPs to work in this way. I'll go to the next slide. You can see I'm flying through them, Michelle, just to give people a sense of improving health outcomes. Absolutely #1 priority, I would say, in terms of the long term. And if we want to leave a legacy, we do need to get people out of hospital. I'll come back to that in a moment. But really about helping people get access to good healthcare all the time, from GPs, from hospital. Well, we are seeing some really good examples where hospitals have fast-tracked people on their elective waiting lists. And what a great thing to do, because you know immediately the chances are you're saving lives, or at least you're improving quality, or you're improving outcomes. So there's a lot we can do. We're doing the annual health checks, really some good work. We're seeing it particularly this year, and we have a program about those who've had not the annual health checks, rather than just repeating the same number as we had last year. There's a lot of people out there who've not had an annual health check for years. Equally, we've had a lot of people who are on the leader report who have died in 2021, who've had an annual health check, and clearly the quality issues are going to be important. The quality of that, the plan, and what are we doing? And if you go back to the 49% of avoidable deaths, really important we link that up. So this isn't something just for a small program. This is something for the NHS and social care across the board, whether it's respiratory, cardiac, cancer. All those pathways need to make real provision for people with learning disability or autistic people. Next slide. Next slide, please. Thank you. Improving outcomes for children and young people, really, really important, both at hospital and in patients. We are seeing the key workers, real successes in the key worker program in helping keep people out of hospital. However, we still have a large number of people in hospital. We're probably on track with the target, but I think any young person in hospital for any length of time is probably too long. We need to think about their life cycles. And clearly sight, hearing, dental checks for children in residential schools is a really important part of our work. And it's really important that we work across government portfolios to make sure that we look after people early. Next slide. Autistic people, and there's a question that I've come and seen earlier. Autism is not an illness. People who are autistic, it's the way they are, and we've got to make, and I'm reminded by autistic people who are on our program, they tell me every day, this is not a disease, Tom, this is not an illness, this is who I am, you need to make provision to help me. So 3 strands of work really about developing a framework to help improve access to diagnostic services. A lot happening there, a lot of good work around pathways, but we are seeing a significant number of people, adults particularly, on a waiting list for a diagnosis. Now, a lot of conversations happening now about not waiting for a diagnosis and bringing people expertise on about earlier needs-led focus rather than just waiting for a diagnosis. Reviewing the autistic deaths is really important as well. It hasn't been done. Health checks for autistic people are part of our work, and really about environments and sensory and awareness of the care, treatment, and where environments are that best help autistic people. So a big program of work, underfunded at the moment, I would say, and I'm not afraid to say this, and we are pushing centrally that there needs to be significant more funding for autistic people. That said, seen some fantastic work in ICSs supporting autistic people, and long may that continue. Next slide. Capable workforce, I'll leave that. I think Chris talked a lot about building a capable workforce, and this is something we've got to do across all the health and care sector to make sure that we build the right staff, the right people, with the right culture, with the right minds to look after people with the learning disability and autistic people. The Oliver McGowan training, a really key element of that. Delighted that's been rolled out, and we're encouraging everybody to access that where they can. First, level 1 is online at the moment. Final couple of slides, if I can. Next slide. So looking to the future. So how I see it is we clearly need to help those people who've been in hospital for a long time. And we're seeing some really good successes of people who've been in hospital for 38 years. I spoke to Kelly last week. She's 28 years in hospital, 13 of them are in seclusion, and she's probably 6 months from discharge. Really, really good stuff. But why 13 years is good? So we need to think about it. So we really need to get this sorted long term. We need to make sure that we're not admitting people and keeping them longer. And I know in terms of our targets, if we manage to get people in and out of hospital more quickly, we'll achieve that target. But there's still too many people who've been in too long. The biggest priority, I think, of all is improving health outcomes. Really, really important. Health inequalities, equal access, appropriate care and support for autistic people and people who learn disability. Right care and right support for autistic people, and developing integrated community provision important. The one thing I've been asked to put on this is looking to the future, and particularly a priority is employment. And I'm reminded several times about 5 to 6% of people with learning disability in employment. 20% of autistic people in employment, so there is much to do. And if Katie was here, you'd be listening to Katie full in employment with us, delivering what is a fantastic service and an absolutely excellent contribution to our team. Next slide. So, questions we're asking of people, and Stephen mentioned this. We're speaking to chief execs and leads of ICSs and people who influence up and down the country. Do you know the history of people in your services? And one of the things I think is what we've done with people who are in hospital for a long time is we put them in hospital miles away from our home and forgot about them. These are not names, these are not numbers, these are names. So we want every ICS to know their people in hospital and know their community. We've seen it work with the first level of vaccinations. We've seen people being picked up quickly and getting the vaccination early. What influence can you bring to system partners who have been and get people support? How can you work with your ICBs and executive leads in terms of influencing this agenda? And really good that the partnership you've got, Michelle, is really dedicated to learning disability and autism, a real opportunity here. And what more can we do to best support the physical health and well-being alongside mental health needs of people with a learning disability and autistic people? So the quick canter through of the national picture and the national drive, really, really important agenda this. We've got to keep working together. We can't just do it nationally. We can't just do it on the agenda for learning disability and autism. We've got to work with colleagues in primary care, in community and in acute hospitals to make the difference we want to. But thank you for listening. Happy to take any questions. Michelle, I'm conscious of your time.
Thanks, Tom. We've got a few, but I'm going to park them because we're going to go on to the Q&A session, Tom. So plus, if you give you a quick chance to have a look at a couple of them that are in the box, so we can come back to those. So thank you for the questions. Please keep them coming. And I think you're absolutely right around focusing on strengths of people, not weaknesses. But I also think that we are talking about targets, and hopefully one of the things our collaborative will do is not talk about targets, but talk about people, because they're absolutely right. These are people. So that's great. So let's just move on to Brent, and then we'll come back to the questions. So please keep your questions coming out. I won't miss any out. So I'm handing over to Brent, who is going to take you through, and it's quite useful. I used to do this. It's actually quite nice to chair, actually. But I'm going to pass on to Brent, who is the chief executive of TSS Vala, who is chairing the collaborative. The collaborative's been going for about 5.5 years now. I've been privileged to work all the way through with it. So I'm going to hand over to Brent, who's going to set the scene a little bit around our collaborative. Then we'll have some questions and answers, and then we'll have a short break, and then we'll go on to the Professor Marmot, if that's okay. So good morning, Brent, and I hope you're okay.
Good morning. Thank you, Michelle. Yes, I'm very well, thank you. And it's good to be here at the conference, and it's great to see that so many people have joined us this morning from all over, actually, in terms of, I guess, the geographic pull for the conference. My job this morning is just to talk a little bit about the work of the collaborative. As you said, I picked it up in terms of the chair role of the collaborative in July of this year, and it's been a real privilege to work alongside colleagues to I guess further the work of the collaborative. Could you just go to the next slide, please? Just to, I guess, remind ourselves what we're about, really. This is about the main organisations from across the ICB patch getting together and working through, I guess, the key issues associated with mental health, learning disability and autism services. We work across the 6 places. We're focused on where we can work together to achieve large-scale change. So, for example, community transformation, where we can look at how we can standardise or set standards for care so that we can eliminate variation, and also how we can bring people together to share best practice. We also play a key role in terms of allocating things like transformation resources and making sure that we can resource some of those kind of key aspects of work. And we've been really successful in drawing in resources to the region and to the ICB to allow us to do pilot programs and participate in vanguard schemes and those sorts of things, so that we can establish, I guess, some of that best practice and share that regionally and nationally. Next slide, please. As Michelle mentioned, we've been together as a partnership for probably 5 years, and I think it has moved us on a hell of a lot, really, from what we see here. You may have seen this slide before, where before we didn't share, we didn't work well together, we didn't have good conversations always, really, around some of the opportunities for us to work together. And if we move to the next slide, I think it's fair to say that we've built our relationships. We've got a positive way of working, a collective sense of common purpose, and whilst we don't always agree, we actually have a mature and sensible conversation and work things through, and we can I guess draw on our collective resources to move things forward. Next slide, please. So what are we doing? What are we doing as a partnership? Well, these are our priorities, and there are 12 work streams, as you can see there, and you could probably map the majority of those from the long-term plan to what's going on in the local priorities, and clearly there'll be a read-through from the long-term plan through our ICB collaborative programme and into the work that goes on in each of our 6 places. For each of these, we've got a programme support, we've got a dedicated team, a talented dedicated team who I'd like to just thank for their support, who are working through these aspects of our work programme. And clearly, you know, we do this through working with the various constituent organisations as part of our partnership, working with patient groups, carers groups, as well as colleagues as we work through these. And we do have excellent clinical engagement, which I'll talk a little bit more about later. Next slide, please. So I'm just going to go through a couple of slides where we showcase some of our I guess, key achievements, really, and some of the main things. I talked about pilots and vanguards. We're going to hear a little bit more about some of these programmes later on in the agenda. But you can see, you know, we put ourselves forward, and we've been successful in achieving a slot as one of the 10 national vanguard sites to deliver the CYP trauma-informed care. There, we have completed 68 of the safe and wellbeing reviews, which Tom alluded to earlier, and that means that we're in a position where we're now focusing on the quality of care, making sure people are in the right place. And it is that focus on people as individuals and making sure that we're getting things right for them. We've also launched our perinatal services, and we're doing great work there, and building on that with the maternal mental health work that rolled out from this summer, which obviously looks at how we can provide maternal mental health support to people in the maternity hospitals, in the actual acute trust settings. And as you can see, we're taking the opportunity to try and celebrate some of our success by applying for HSJ awards, and we were lucky enough to be highly commended as Integrated System of the Year around the work on maternal mental health and the trauma-informed children and young people care. Next slide, please. Just in terms of, I guess, some further work that we've been doing, again, more pilot work that we applied for. We're one of 2 pilot sites in the northeastern Yorkshire, where we've been looking at rough sleepers, the work in East Riding, working with social care and community services, where we're looking to obviously extract learning so that we can think about how we can embed and roll out, I guess, further those types of opportunities. Similarly, with the type 1 diabetes and eating disorders, the service will be launching very soon in Hull, East Riding and North East links, and a great opportunity for partnership working across the community with the community collaborative. So working across our collaboratives in the Humber North Yorkshire. I mentioned earlier community transformation. We had a really, I think, positive start to the programme with the Hull and East Riding rollout, and now that is extending right out across the 6 places, and massive opportunities for us to I guess reinvent the way that community services work, particularly partnering with the voluntary and community sector and embedding different ways of working and looking at workforce models as part of that approach. And we've talked a little bit this morning already about annual health checks, but this time focusing on people with severe mental illness. We've been able to secure funding to allow us to digitise and to work at different ways of actually furthering our endeavours around annual health checks for people with severe mental illness. Next slide, please. So just taking a look ahead, some of our key priorities obviously do follow through from our work this year. We will continue to roll out the mental health teams in schools. Clearly we'll have a focus on access. Again, that's already been mentioned this morning, particularly with regard to children with eating disorders or suspected eating disorders. We'll continue to embed the various other aspects of the trauma-informed care, which again we will hear more about later. Perinatal mental health, there's those really important parts, particularly with the themes that we're talking about today around inequalities and trying to get a great start in life for people. Increasing the psychological interventions, thinking about support for fathers as well as the mums, and moving things forward to deliver an integrated psychologically led service for women and families. Learning disabilities and autism, again, Tom has eloquently talked us through some of the national issues here, but clearly we will be focused very much on health checks, the physical health, because of the real stark inequalities in outcomes for people with learning disabilities, a real focus on bringing people back to the region from out of area, and we're already gearing up to roll out the Oliver McGowan autism training across the ICB into all of the care settings across the piece. Lots of pressure on beds within the region and within the ICB patch. We're really working hard already, and we'll continue to focus on out-of-area placements. Clearly, not only is this a quality issue for people and an experience issue for people, obviously it will allow us to invest more of our money in enhancing quality within our own services within the area. And linked to that, crisis and urgent mental health care, expanding mental health crisis teams and liaison services in acute hospitals, thinking about crisis access for children and young people, working with our colleagues in the police around right care, right person, as well as continuing to work with the ambulance service on our response. Next slide, please. I mentioned clinical engagement earlier, and I just want to pay tribute to Dr. Stella Morris and Dr. Steve Wright, who have led our clinical assembly. Our clinical assembly brings together clinicians from right across the disciplines, from right across the ICB on a regular basis, and they've already got a packed programme for the year ahead, where they're going to be looking at some really key issues this year. As you can see, some of the subjects that they've focused on so far, they're really embracing some of the challenges that we face, some of the wicked issues, and applying, I guess, a clinical perspective to support us with key advice to allow us to make better decisions around how we transform services. Next slide, please. Clearly, there are a number of challenges. We've set our priorities for the coming year, as I've outlined, but on an ongoing basis, we know that we've got these challenges to focus on. Workforce has been mentioned inevitably several times already today. Clearly, there are significant pressures around staffing, huge issues around the use of agency and those sorts of things that we need to, as providers, continue to focus on. We're participating, obviously, in the ICB workforce strategy led by Jane Adamson and Jason Stamp, and clearly doing our bit really in terms of the individual aspects of mental health, learning disability and autism services to make sure that we can continue to recruit and also importantly retain people within services. One of the things that's been really, I think, positive in the last month or so is that we've had a delegation out to Kerala in India, where we've been doing some ethical international recruitment, and I know that that was a really positive experience with several hundred colleagues or potentially new colleagues being identified and brought to the UK, and we look forward to welcoming them in the new year as part of that approach there. We do have some ongoing challenges around money. We obviously have been successful in securing a huge amount of investment for services locally. Some of that has been non-recurrent, which means that now we need to focus on how we can find sustainable funding solutions for those, and that includes things like the Health and Wellbeing Resilience Hub, as well as maternal mental health programme, and clearly our really important suicide prevention work. And one of the other challenges, just to mention before we wind this section up, is just the ongoing focus on performance. We try to be ambitious in the way that we set targets for ourselves. Clearly, we are monitored a lot against the long-term plan trajectories. Because of the financial constraints, sometimes we have not set local trajectories that match the national ambitions, and we maintain good discussions with our colleagues within the regional and national team around how we can support, I guess, progressing against those targets, whilst obviously we prioritise things like the access target metrics and so on. Next slide, please. Clear, again, it's been mentioned already, following the Panorama programme and also the Dispatches programme, with the experiences of people in Manchester and in Essex. We've got a real focus on quality, real focus on challenging, I guess, ourselves to make sure that we are clear that, you know, we're not complacent about the level of care that we offer within our inpatient settings. We've just undertaken a piece of work across the organisations, the main providers of inpatient services within Humber, North Yorkshire, where we've assessed ourselves against the CQC's inspection guide around closed culture, as well as looking at a range of other metrics and information. And the chief nurses from each of the organisations have worked together to undertake a piece of assurance work around the quality of care being delivered in the respective units. That's going to lead to some further collaborative work over the coming months, where we're going to be looking at peer reviews across and between organisations, as well as revisiting that work over a regular sort of schedule in the coming months, and liaising with the quality committee at ICB. Next slide, please. And of course, as Stephen set up at the very beginning of the session, today we will be announcing the launch of our 21-22 annual report. That will be made available to you electronically with the slides after this event today. And clearly that showcases the achievements of the last 12 months, and you'll have an opportunity to look in more detail at some of the things that I've highlighted this morning, as well as a wider array of other things to look at. So thank you, Michelle. I will stop there, and more than happy to participate in any questions and answer any I can. Thank you.
Thanks very much, Brent. Great presentation, and thank you for taking us through that. And yes, there's a lot of work being done, and a lot of challenges ahead, and a lot of successes as well. And I think it's that mixture that is so important. And for example, our out-of-area placements have dramatically increased on year, but we've got some pressures in relationship to learning disabilities, repatriation, because of the complex nature in the market, and checks. But we've got really good plans. So, but again, it's all in the report as well, and this is a good forum where we do launch our annual report. I'm going to say welcome back to every speaker that we've had. The way that obviously Teams presentation works is that I will direct the question to somebody and then they'll come back up on screen, but the panel are with me. I can trust you. I can see all their faces. So we've got Brent, Chris, Tom and Stephen with us. We have got a couple of questions, so I'm going to go through those if that's okay. And I'm going to start with I suppose a bit about a system really. I'm going to throw it to Stephen if I can first, and then maybe think myself and Brent potentially. But this was about the balance. This was one that was pre-submitted, so it's about the balance for transformation of a system and giving the best start in life. And that's obviously one of the core ICB priorities, and meeting the existing needs of the spectrum of the population. So Stephen, do you want to maybe kick us off with that? Welcome back.
Yes, thanks, Michelle. Well, that's a great question, whoever asked it. I think very specifically in this particular case, and why I say very specifically is because I think you could amplify that question to the ICS more generally. It's a real challenge to balance all the demands of the here and now, so managing today with all of those wider pressures that we all know and are experiencing, with keeping an eye on the ball really around the longer term aims. So if you think about starting life well, that's about longer term investment in addressing those communities that are most challenged, with the most challenged families, where we've got the highest rates of unemployment, where the average lifespan of men and women is 10 to 15 years below the national average, down our coastal area, in Hull, in parts of rural North Yorkshire. So if we're going to make an impact on starting life well, then one of our key focuses needs to be on those communities, and that's not a short-term game. Clearly we need to do what we can now, but that's about differentially investing in those communities to make progress against bringing, back to the title of the, I'm not sure I like levelling up particularly, but it is what I am talking about is levelling up. So absolutely, we need to do what we have to do now in very trying circumstances. But I think for the collaborative and our mental health providers and for the ICB, we need to remember that 3 of our ambitions are longer term. Supporting our community and our local authority colleagues in particular in socio-economic recovery, organising ourselves on the basis of our population health needs and addressing health inequalities and wider inequalities. So great question. Striking that balance is not straightforward, but I'm sure you'll all join with us in trying to achieve that.
Thanks, Stephen. A great answer. I'm going to move on to we've got a couple more questions we should be able to get. We'll still have a little bit of a break, and we'll make some time back, so don't worry. But I just want to go on to one about the Oliver McGowan training, because actually I've done that and it is fantastic training. It's probably the best training programme that I've done for a long time. But one of the questions we've got, Tom, is how can NHSE and the ICBs ensure that Oliver McGowan training is successful? And I suppose really what the question is, Tom, what would define a success for you or for NHSE?
So thank you. Look, really good. It's really good training, and actually, Michelle, delighted that you have done it yourself. And actually, that's what we would want to see happening: is leaders doing it and talk about it, and make sure we drive it through the system. It's not the only training. There's other training out there. There's people would say there's other training that's been there beforehand. Success for me, there would be about greater awareness of the need and support that autistic people need. So you could argue within acute hospitals, A&Es, a number of staff in each team are trained and aware and talking to each other. So that really would be the first level for me, that in teams across the NHS, in social care, that would be aware of the needs of autistic people. I'm a mental health nurse by profession, and I was never trained to support autistic people. Actually, the way I think mental health nurses are trained is contrary in times, particularly around restraint, touch, environment, noise, acoustics, sensory, all of that kind of stuff. So I'd really want to see a real turnaround there, that in mental health trusts and mental health wards, you have a significant number of people who are trained at different levels, but an awareness of the provisions that we make, the reasonable adjustments that we make. So very hard to quantify, but I don't see it as a national measure. I think it'll be something locally, and people like yourself just driving that through and Stephen driving that through the ICBs and ICPs. There is another question in there, and I'll just hit it, where autistic people have needs in their own right, not necessarily related to mental health, not necessarily related to learning disability. Autistic people need to be looked after in their own right. And it is right that we think about autistic people in their entirety, whether they access GP practices, whether they access acute hospitals. It's really important, and we should use the training to as a basis for that awareness.
Thanks, Tom. There are a couple of questions in the chat box around children and young people, but if the audience can bear with me, I'd like if we can pick them up in the second session, because we're going to pick up a little bit about children and young people. So Brent, I'll leave those with you. There are a couple, but I think they go better when we talk about our trauma-informed care, if that's okay. But Jean asked a really good question, actually, which is around dementia support, and I'm going to ask Brent this one, really. We're not chatting much about dementia support. I know that we are doing quite a bit in the collaborative, but maybe could you just give us a bit of an update, Brent, on some of the initiatives and some of the work that we're looking at in relationship to dementia?
Yeah, absolutely. And apologies to Jean, actually, that it hasn't come through the presentation as probably as clearly as it might have done. It is a priority for the collaborative. We've got a significant piece of work which has been led by Gemma, one of our colleagues. You'll see more around this in the annual report. We've been doing quite a bit in terms of looking at new ways of looking at dementia diagnosis, as well as ongoing dementia support. So we've got various pieces of work that are being piloted across the ICB, looking at a number of different possibilities around that to shorten some of the waiting times, which is clearly a worry for us at the moment. Working alongside also our acute care acute colleagues, particularly looking for things like access times to scans and so on. So yeah, we have got to focus on dementia support, and we've got a clearly a role to play in, I guess, in drawing some of that out. Have a look at the report, Jean, see what it says in there around the work that we've been doing, and by all means, let's follow up and we can hook you up with a conversation with Gemma.
Thanks, Ben. And then I suppose a final question for Chris, really, around any top tips from the CQC regulator from a collaborative point of view, after what we've been chatting about up to now around some of our priorities and work. Any top tips for how we can continue that flexible approach that you mentioned earlier on?
Thanks, Michelle. Yeah, really good question to reflect on. And like I said earlier, we have a great opportunity because we move around across the country to see different practices and to see how people are working together. But I think one thing I've been really impressed with is listening to Brent, Tom, and listening to you, Michelle, in terms of what you're doing here up in Northeast. I think the system approach, it's the best way forward, I think, if ever we're going to tackle some of the challenges we've been talking about, whether it's workforce, whether it's access. It's actually that system approach and the collaborative you've got here in Humber, in North Yorkshire. It's a good good example to see actually how best you can continuously address some of the challenges. And that's what we are seeing across the board. And we are really interested, I think, from April onwards, when we do more work around integrated care systems or integrated care boards, is that really looking at that partnership working. And we are keen to see that partnership working, that collaborative about systems coming together to address some of the challenges. Because as one system, you can't, successfully, address some of those challenges. So for my recommendation, my advice is what you're doing here is the best way you can address some of those challenges. And it's good to see. Actually, I'll go away to talk about what I'm seeing here, because this is actually what we are looking for, systems coming together and working together to try and address some of those challenges. And like I said, in terms of workforce, what we are seeing across the board is people starting to think about how you use other roles, moving away from the traditional roles. Because, for example, people talk about mental health nurses. They are not mental health nurses. They are not enough. So what else can you do as a system to think about alternatives in terms of actually making sure services are safe, instead of continuously looking for mental health services? And we are all, I think you're all fishing from the same boat, really, to try and get those nurses. So think about actually collectively as a system, how do I address by addressing these challenges by looking at other roles within mental health services. And the last thing I'll say is, I think we are seeing across the board, some areas are doing a lot of work of getting people with lived experience more and more involved in the work. I think it was great to see what Tom was talking about, Kate. And I think that's what we'll try and encourage people, because they'll bring a different aspect in terms of how they look at how services are being delivered. But a lot of people are starting to think about actually people with lived experience. How do they contribute into some of the improvements you might be thinking of doing?
Thank you very much, Chris. I'm going to leave the questions there. I have got a few, but I'm sure people will write in the answer boxes as well. And we'll defer a couple to the afternoon. I do know that Professor Sir Michael Marmot has joined us, but I'm going to just suggest that we all have a quick comfort break. Just take a bit of a break from the screen, grab a quick cup of coffee. Thank you sincerely for my great guests this morning, from Stephen to Chris to Tom to Brent. I'm going to hand over to Brent to chair the next session, but thank you everybody. A round of applause. It's been a really informative, and I know the next session will be, but thank you so much for starting that conference off and giving us that national picture. And if we just have 5 minutes, we come back at 1:45 and then we can get straight into Professor Michael Marmot's session, if that's okay. So thank you all.
Hello, everybody, and welcome back to the second part of this morning's conference. This second part of this session will be focusing on mental health inequalities. We're going to open up in a moment, and I'm going to be introducing Professor Sir Michael Marmot. We'll also be joined later this morning with some local speakers who are going to take us through a kind of life course approach, updating on some of the key initiatives that we've been taking around this agenda. And we'll have a couple of opportunities for question and answer. Once Sir Michael has spoken, we'll have some questions for Sir Michael, and then obviously at the end of the next session we'll have a panel discussion with colleagues involved in those key pieces of work that we'll be hearing about. It's a real pleasure to be able to introduce Sir Michael Marmot to you this morning. It doesn't take much introducing, I'm sure, to most of you. Sir Michael is the Professor of Epidemiology at the University College London. He's been the author of some really significant and really important reports on health inequalities, which I'm sure many of you will be familiar with. He's been an advisor to governments and the World Health Organization, and he was knighted for his services to epidemiology and understanding health inequalities in 2000 by Her Majesty the Queen. So Michael, welcome to our conference this morning. It's really good to see you. You look very well wrapped up there and warm. I'm hoping that we can hear from you this morning, your views on health inequalities, and I'm looking forward to colleagues putting questions in the chat so that we can get a bit of discussion going for a short time afterwards. So Michael, over to you.
Thank you. I am rugged up warm. I'm trying to feel empathy with people who can't afford to heat their dwellings. And I'm not going to talk specifically about mental health, but everything I say does apply to mental health. I've said for a long time that anyone concerned with social determinants of health has to be concerned with mental health, and anyone concerned with mental health has to be concerned with the social determinants of health. I called this Build Back Fairer, is the title I gave to my COVID-19 report. The argument being that we shouldn't seek to re-establish the status quo before the pandemic. It looks like we're building back. Well, it doesn't look like we're building back at all, let alone fairer. So we've got three big challenges to health inequalities. The opening line of my book, The Health Gap, was why treat people and send them back to the conditions that made them sick, particularly at a time where the NHS has been pushed to the limit. Our loyal NHS workers are not being paid properly. There's 130,000 vacancies. We care a great deal about the health care system. My concern, though, has been and is and will be with the conditions that make people sick, with the social determinants of health. And the three recent challenges to health inequalities were a decade of austerity, the COVID pandemic, and now the cost of living crisis, and each built on the one before. In 2010, I published the Marmot Review, Fair Society, Healthy Lives. It came in the wake of the WHO Commission on Social Determinants of Health that I chaired. We published the WHO Commission report in 2008, and we said on the cover, social injustice is killing on a grand scale. The then Prime Minister of the UK, Gordon Brown, asked me to conduct a strategic inquiry to answer the question, how could we apply the findings and recommendations of the Global Commission to one country, England? And I produced Fair Society, Healthy Lives. 6 domains of recommendations: give every child the best start in life, education and lifelong learning, fair employment and good work for all. Number 4, highly relevant with the cost of living crisis, create Number 4, everybody should have at least the minimum income necessary for a healthy life. Number 5, healthy and sustainable places and communities. And the 6th is taking a social determinants approach to prevention. In February 2020, just before the pandemic crashed upon us, we produced Health Equity in England, the Marmot Review, 10 years on. The question is, what had happened in the 10 years since my earlier review? And the news was not good. Life expectancy had been improving about 1 year every 4 years. That's 1980. I could take it back to 1900, and it had been improving about 1 year every 4 years for women and for men. And in 2010, there was a break in the curve. The rate of improvement slowed dramatically and just about ground to a halt. Question is, what happened in 2010? Well, we had a new government elected, the Conservative-led coalition government. They said, surely you can't be suggesting it's anything we did that led to this slowdown. Well, we should look at it. They said, perhaps we've just reached peak life expectancy. So we looked at other countries. Estonia, Norway, this is annual life expectancy improvement in weeks. Estonia, Norway, Slovakia, Hungary, Denmark, UK. We had the slowest improvement of any rich country except Iceland and the United States. No, we had not reached peak life expectancy. And we had an increase in inequalities. Life expectancy follows the social gradient. Here I've got women in the least deprived 10% and the most deprived 10%. And each of these represents a region. If you're in the least deprived 10%, life expectancy was going up a bit and the regional differences were quite small. If you're rich, it doesn't much matter where you live. If you're poor, it matters enormously. The regional differences are much bigger. Life expectancy was going up in London and going down in virtually every region outside London. So this is where we were pre-pandemic. Life expectancy had stopped improving. Health inequalities were increasing, and life expectancy for the poorest people was going down. You can see why I said build back fairer. Let me show you the regional differences in a bit more detail. This is London and the Northeast. If you're in the least deprived decile, the differences between London and the Northeast were quite small. The top one is London. And then the greater the deprivation, the greater the health disadvantage of living in the Northeast. Or to put it a different way, the social gradient by level of deprivation is steeper in the Northeast. Now, if we look at time, the dotted line is London 2010-12 and the solid line 2016-18, and you can see that life expectancy in London improved a bit right across the gradient. In the Northeast, life expectancy fell in the poorest 10%. It didn't improve in the next decile, or the next, or the next, or the next, or really the next. It's only the top 40% where there was some improvement. Really interesting. This is a national index of multiple deprivation, but it predicts health more strongly in the Northeast and the Northwest than it does in London and the Southeast. In my 2010 review, I coined the phrase proportionate universalism. I was trying to combine two ideas. The classic British approach to social policy is you target the worst off, means tested benefits, free school meals, etc. A more Nordic approach is to have universalist policies. My suggestion is we should combine them. Proportionate universalism, universalist policies with effort proportionate to need. We could call it levelling up. There you are. So here's the social gradient, let's say, in life expectancy. The greater the affluence, the better the life expectancy. We want to level up. If we focus only on the poorest, we miss the health disadvantage of those above this dividing line. So universalist policies with effort proportionate to need. What did we get post 2010? This is spending by local authorities per person. Much of that, of course, is derived from central government. In the least deprived 20% of areas, the spending went down by 16%. And then the greater the deprivation, the greater the reduction. In the most deprived quintile, the spending went down by 32%. What we've got here is effort inversely proportionate to need. The greater the deprivation, the greater the need, the greater the need, the greater the reduction in spending. Could this have played a role in the slowdown in health improvement, the increase in inequalities, the decline in life expectancy in the poorest areas? Yeah, I think it could. I'm not going to go through all 6 of my recommendations, but let's start with children. Children living in poverty. Poverty is defined as living in a household at less than 60% of median income. Before housing costs in 2010-11, 18% of children were in poverty. After housing costs, housing is a significant contributor to poverty. 27% of children were in poverty, and that 27% went up to 30%. How was that achieved? Changes in net household income due to tax and benefit reforms. So the red is working age with children by household income decile. If you were in the poorest 10% of household income, as a result of changes the Chancellor made to tax and benefits, your income would have gone down by 20%. If you were in the next poorest decile, your income would have gone down by 12%. And then the richer you were, the less the reduction. Some reduction at the top, but nowhere near as big as the reduction at the bottom. The Chancellor's policies were to make poor people poorer and increase inequality, and quite successful. And it doesn't have to be like that. These are OECD countries, UNICEF report card 16, Iceland, Czech Republic, Denmark, Finland, Korea, Slovenia. Child poverty, 10 or 11%. The mode of calculation is slightly different to the one I just showed you. The average was 20%. Here's the UK. We rank 31 out of 41 countries. The US ranks 38th out of 41 countries. And this is a matter of policy. Before redistribution through tax and benefits, child poverty in Finland is higher than in the United States. The Finns don't like their children to grow up in poverty, so they use the tax and benefit system to reduce it. The Americans are very happy to have their kids in poverty, and we're pretty happy to do that too. We rank 31 out of 41 rich countries. It's a political choice. Public spending on early child education and care. Total spending per child aged 0 to 5, the OECD average is $6,000 per child per year. In Norway, they spend 12,000. The average is 6. We spend 4,000. We keep hearing our leading politicians talk about world beating this and world beating that. We're not world beating anything. We're limping along below average on child poverty, on spending on children. We're not the worst. The US is worse than we are, but we're not very good. And this is crucial to the future of our country, as well as the future of today's children. Spending on education. Real terms change year on year by level of deprivation. In the most deprived, 2015 to 16, spending per child went down. And then for the next few years, it went down across the board, but most for the most deprived children. And even when it improved, spending improved during the pandemic, it improved more for the less deprived. What is this about? If you're a poor child, we're going to spend less on your education than if you're from a well-off family. This is a policy designed to increase inequalities. Exposure to air pollution, percent of children living in poverty, PM 2.5 levels, there's a correlation. The greater the percent living in poverty, the greater the exposure to air pollution. I waited 10 years to do my 10 years on review. I waited only 10 months to do the COVID-19 Marmot review, which I called Build Back Fairer. We said from the beginning that the pandemic would expose and amplify the underlying inequalities in society. Here's the social gradient in all-cause mortality by level of deprivation, and here's the social gradient in COVID-19. It looks almost identical to the gradient in all-cause mortality. Slightly steeper for COVID because we think people working in frontline occupations in the most deprived deciles and living in overcrowded housing. But it means, important as the control of the virus is, vaccination, absolutely amazing to develop the vaccine so quickly. We need to deal with the inequalities. If I put depression on this scale, the social gradient in depression looks like the social gradient in COVID-19. We don't think depression's caused by a virus. Vaccination won't cure depression. It means we need to take action on the inequalities. And I said it would amplify the inequalities. These are ONS figures for the 3 years life expectancy, for the 3 years 2018 to 20. Most of what I'm showing you is influenced by the pandemic 2020, compared with the previous triennium by deciles of deprivation. And life expectancy fell for the poorest 40%. Before we were talking about the poorest 10%. Now it fell for the poorest 40%. In fact, for men, it didn't improve at all across the whole gradient. For women, it improved in the top 60%, but fell sharply in the bottom 40%. And so for women now, those figures 2018 to 20, women living in the most deprived areas of England are expected to live a third of their lives in poor general health. So not only do they have shorter life expectancy, but they spend more of those shorter years in ill health. US colleagues did this. These are US figures for change in life expectancy from 2019 to 2020 and 2021. You can see life expectancy dropped sharply in the US, sharply. And they compared with what they called 19 peer countries. And the countries that did next to the US in doing badly was Scotland, Northern Ireland, Germany, and England and Wales. Wow. We did really badly during the pandemic. Not as badly as the US, but badly. So what's going on here? I think of health as a measure of societal success. Pre-pandemic, life expectancy in the UK was stalling, inequalities were increasing, and life expectancy for the poorest people was falling. And that slowdown in life expectancy was nearly the slowest of all rich countries, except Iceland and the US. In the first wave of the pandemic, we had the highest excess mortality. Over the 2 years, we had the biggest drop in life expectancy, except for the United States. So what's the link between poor health performance pre-pandemic and poor health performance during the pandemic? I think poor governance and political culture. If I get asked, what do you mean by poor governance? I say, count up how many prime ministers we've had since the Brexit vote. I think 7 chancellors of the Exchequer since the Brexit vote. Do I need to define poor governance and political culture? Social and economic inequalities are increasing. The reduction in spending on public services, we're ill prepared, and we weren't very healthy. You see why I say we need to build back fairer. Now, the third challenge is the cost of living crisis, which perhaps over the top I've described as a humanitarian calamity. It's not just Britain, of course. Across several major European nations, a majority say their household cost of living has increased in the last year. Spain, 83% say it's increased, Great Britain 80%, and that will have gone up even more. Housing, coming back to the UK, housing and energy costs have increased by 26.6% since October 21. That's October figures. One's always out of date with this, it's moving so fast. So this is up to October 2022. Housing, water and energy went up by 26.6%. Food and non-alcoholic drinks went up by 16%, and then other things. And what that means is when we look at inflation, if inflation is 11% in the richest quintile, it's just under 18% in the poorest quintile. So when we hear that the headline inflation figure is 11%, think 18% or higher for the poorest quintile. Why? Because food and energy are particularly hit by inflation, and they make up a very high proportion of the spending of those in the poorest 20%. To the extent that ambulance drivers and nurses, some nurses are in that poorest 20%. Can you imagine why they're not terribly happy with a 4% pay offer when inflation's running for them at 15, 16, 18%? On the 1st of September, we produced a new report on fuel poverty, cold homes and health inequalities. We said thousands will die, the excess winter deaths, and millions of children will suffer from fuel poverty. The direct effect of cold homes on health, respiratory conditions, cardiovascular disease, the excess winter deaths, poor mental health. The mental health of children suffer if they grow up in cold homes, and these other things. And the indirect impact, stress. If you can't make ends meet, if the juggling of heating and eating, if the catastrophe of children needing a new pair of shoes, the stress of trying to make ends meet has a significant negative impact on mental health and will impact on the early child development of children. 1 in 4 adolescents living in cold housing at risk of multiple mental health problems, compared to 1 in 20 adolescents who lived in warm housing. Children who grow up in cold homes do less well in school. And 21.5% of excess winter deaths from living in a cold home, and 10% from fuel poverty. The drivers of fuel poverty are 3: household income, the cost of energy, and the energy efficiency. This is not simply about the war in Ukraine. Poverty has been increasing since 2010. It's a long-term effect. The cost of energy, our energy market is completely and utterly bonkers. You, perhaps, like me, thought that the price you pay for a good is the cost of production and distribution plus some profit for the producers. Wrong. We don't pay the average cost of production and distribution. We pay the marginal cost. The cost of the last, most expensive unit of energy applies to a whole lot. 60% of our energy comes from nuclear and renewables, about 1/3 from gas. If the price of gas goes up, we pay more for wind power. What? Because we've got this totally crazy dysfunctional energy market, people are shivering and dying this winter. And energy efficiency, the government stopped investing in energy efficiency in 2013. They decided, no, we're going to cut everything. We'll cut expenditure on energy efficiency. Bad for the planet, for net zero greenhouse gas emissions, and bad for people's health. And it's not just that people can't be bothered working. This is working age adults in working families in poverty. So 2/3 of families in poverty are in a household where at least one adult is working. Nearly 1 in 5 residential care workers are in poverty. Frontline workers in social care, their average wage is less than the real living wage. And we've got a bigger problem of inequalities than other European countries. Look at this. In France, the richest 10% spend about 6% of their income on energy. In the UK, the richest 10% spend about 6% of their income on energy. In France, the poorest 10% spend 10% of their income on energy. And in the UK, the poorest 10% spend nearly 18% of their income on energy. We have the biggest inequalities in Europe and this crazy energy market. So it means that poor people in the UK are especially affected by energy prices going up. And as I said, the expenditure on energy efficiency fell off a cliff. That's 2012, and there's 2013. Loft insulation stopped, cavity wall insulation stopped, solid wall insulation hardly happened. We've got the worst thermal properties of housing stock in Europe. And the energy price guarantee has made a difference. This is historic and forecast household expenditure on gas and electricity bills going up. The energy price guarantee was going up very sharply, but with the ending of the energy price guarantee, it'll go up even more sharply. But it's been quite good for some. Food and energy billionaires are $453 billion richer than 2 years ago, finds Oxfam. But even with the 10% uprating to benefits, it's going to be a bad year or two ahead. These are vintiles, 20ths of the income distribution. Instability about calculating the bottom one, but you can see if the benefits are uprated, as they have been, by 10%, the drop in income, real income, is going to be quite sharp. And the poorer you are, the bigger the drop in income. A desperate situation. Mortgaged houses, pre-mini budget, post-mini budget, the cost of mortgages will go up dramatically. And if you can't mortgage, if you're not on a mortgage but renting, private rental housing is going up. Interestingly, London, as they're all going up, London's not quite as much, but they're all going up sharply. So mortgages go up, private rentals go up. And people are somehow supposed to look after themselves. You hear a lot of rhetoric about, oh, I could live on low income, poor people just don't know how to cook and use their money. The Food Foundation calculated that if people followed the healthy eating guidance, those in the most deprived 10% of household income would have to spend 74% of their income on food. This is not ignorance about healthy food, laziness about cooking, poor management of money. It's poverty. And don't blame the poor, blame their poverty for their unhealthy food. Campaigners say that 800,000 children living in poverty in England are missing out on free school meals. And food insecurity has gone up dramatically. Food insecurity, going a whole day without eating, not eating enough to satisfy your hunger, missing meals. September 2022, 1 in 6 families without children were in food insecurity, 1 in 4 families with children. In Britain, we used to think of ourselves as a rich country. We're actually not. We're a poor country with some rich people. And we're condemning our citizens to live impoverished lives. And you heard all this garbage over the summer about tax burdens, the highest for 70 years. We are a low tax country. Things change, but this is IMF figures from 2021. Government revenue as a share of GDP. Finland, 52%. France, just under 52%. Belgium, Sweden, 50%. UK, 36%, compared with 50 or more percent. The US is lower at 31%. The Financial Times said that if we raised income tax by 1% of GDP to bring it up to the OECD average, we could meet the so-called fiscal black hole without any cut in public expenditure. You know, if we raised income tax a little bit more, we could actually pay our public sector workers something approaching a living wage. Well, we had the Levelling Up white paper, which was actually very good. I reviewed it for the BMJ, and I was full of praise for the 4 missions, 12 objectives, terrific analysis. But in the Levelling Up white paper, it gave the example of Germany levelling up when Germany incorporated the former German Democratic Republic, communist East Germany. Germany spent, the Federal Republic spent 2 trillion euros over 25 years. That's about 70 billion pounds a year to level up. Did it work? Well, here's life expectancy for women in the West, women in the East, reunification. Yeah, it worked. Men, Well, the gap narrowed. Whoops. The gap narrowed. It didn't quite close, but they made progress. In the white paper, the levelling up budget for the 4 years, 21 to 24, was £4.8 billion, £1.2 billion a year, compared with what Germany spent of £70 billion a year. This is derisory. And in the autumn statement, did we hear about any money for levelling up? IPPR North calculated that the 2021 allocation of the Levelling Up Fund amounted to £32 per person in the North. Compare that with the drop in annual council service spending of £413 per person in the North. Those regressive cuts to local government that I showed you. This is insulting. We'll take £413 a year away and give £32 a year back, and we'll call that levelling up. That's all very depressing. What keeps me optimistic? Coventry, after my 2010 review, declared itself a Marmot city. Greater Manchester said, OK, we'll be a Marmot City region. Luton just issued, we published a report for Luton, said they're a Marmot town. Waltham Forest, Cheshire and Merseyside, Lancashire and Cumbria. Leeds has approached us, said, what do we need to do to be a Marmot city? We've been talking to the north of Tyne. Gwent said they want to be the first Marmot region in Wales. This is really exciting. People in local government, city and regional government, really want to make a difference. So we've had Coventry, Build Back Fairer in Greater Manchester, Altogether Fairer in Cheshire and Merseyside, A Hopeful Future in Lancashire and Cumbria, Luton, and more. And then we were approached by Legal and General. Legal and General have £1.3 trillion under investment. And they said, we want to know if what we do in our day job, in our core business, could improve health and reduce health inequalities. And they said, we don't want it just for Legal and General, but we'd like it for business in general. So we produced a report, The Business of Health Equity, the Marmot Review for Industry. And we said there are 3 domains: pay, good quality work, pay, benefits, conditions, hours. So for employees, for clients and customers, products and services, which could be good for health or bad for health, but let's make them good for health, and the broader impact on the community and environment. Business as anchor institution, like we're talking about healthcare. Interestingly, the East London Foundation Trust, that said they wanted to be the first Marmot Trust, took our business report and said, we're doing it in our trust. East London Foundation Trust as a training and employment provider. Their goods and services for their service users, and having an impact on the wider Luton community. So I finish where I began, but adding something. My 6 domains of recommendations: give every child the best start in life, education and lifelong learning, fair employment and good work for all, having enough money to have a healthy life, healthy and sustainable places and communities, and taking a social determinants approach to prevention. But I've added 2. Tackle discrimination, racism and their outcomes, and pursue environmental sustainability and health equity together. But we also need to address my previous diagnosis: poor governance and political culture, the increasing social and economic inequalities, the reduction in spending on public services, and the fact that we've not been very healthy. Often I get asked, what's the one thing you would recommend? And I say, one thing, I've just laid out a whole agenda, but if one thing, put a fair distribution of health and well-being at the heart of all government policy.
So Michael, thank you. Thank you very much for taking us through your presentation this morning. It's stark, thought-provoking, challenging in many ways, but obviously highlights an important part of our overall Integrated Care Board agenda. We've got some questions for you that colleagues have been posting. So if you're okay, I'll run through a few of those questions. The first one, actually, there are two questions that are similar, which I'll link. So, Michael, you spoke about the importance of social determinants, and resources within the ICB have been allocated on a fair share basis. What would your advice be for planning resources and services across Humber North Yorkshire moving forward? And linked to that, somebody else has asked, if inequality is so driven by national policy, what are the key things that we can do locally within that context to raise people out of poverty? And what's the NHS's role?
Well, let me start with the second and go back to the first. It's a big challenge if national policy is been heading in an adverse direction. And I try to make this, my critique, not be about party politics. I'm not campaigning for a particular party. I'm campaigning for better health and well-being for the population. And if you've got policies that increase child poverty, that's not in favour of better health and well-being in the population. So then the question is, what can be done locally? And in a way, it's an open question, but the commitment. So let's take Coventry, which was the first Marmot city. We haven't got a very good evaluation. It's not a randomized controlled trial, but the percent of children with a good level of development, age 5, went up in Coventry. The percent of young people aged 18 to 24 not in employment, education or training went down. The percent of people earning a real living wage went up. You can work with employers and say, pay people properly. And you know what? Local employers are likely to think that's a good thing. They feel some connection with their local community. We've just been looking at London on actions to try and deal with the cost of living crisis. And it's by no means hopeless, by no means hopeless. That's not a very positive statement to say it's not hopeless, but there are glimmers of real action, whether it's food bank, warm banks, helping people get benefits to which they're entitled, dealing with things in a whole set of ways, which is really difficult. I mean, one of the real insights is how busy you are if you're poor. You know that every day is a struggle from morning till night, thinking about how do I put food on the table? How do I make sure the children aren't freezing? How do I get from here to there? It's so busy. It's such a struggle that a bit of help to get your way through this morass can make a difference. So it's a big question of what can happen locally in the face of national policy that's heading in the wrong direction. But the assumption from all these regions and districts we've been working in is that they can make a difference. And so then to come back in a way to the first part of what can you do in Humber and North Yorkshire, my starting position is put equity of health and well-being at the heart of all policies. So the reason we work closely with people in these districts and regions is if I come in with a formula from outside, they might say, well, yeah, but that's not our priority. We want to do things in a different way. Fine. So we work with regions, and that's why we've done that whole series of reports to say, let's adapt the principles that we have to the realities of a particular situation. But then the last part of the question is, what can the NHS do? We were actually commissioned in Cheshire and Merseyside by the ICS and the ICB. In other words, they were saying, we want to address social determinants of health. I said towards the end that East London Foundation Trust wanted to be the first Marmot Trust. They're saying, we want to, as part of what we do, address social determinants of health. Social prescribing is a move in that direction, but it's not dealing with the big issues. But quite apart, I mean, being an anchor institution is something the NHS can do, addressing the community. I just wrote a preface for a report from businesses that were trying to improve their contracted out services. These businesses had a model that their cleaning and other contracted out services, those companies should pay a real living wage and look at the conditions of employment. So whereas in the past, contracting out meant you just didn't bother, you got cheap services and people were treated abominably. But now there's a move for businesses to say, no, we're going to look at these contracted out services. The NHS can do that. You remember Polly Toynbee's book from decades ago, years ago, about she was parading as a worker for a contracted out service that was contracted out by contracted out service. I mean, she was 3 steps away from being an NHS employee, and it was appalling. Well, we can, NHS is in real trouble. Of course it is, because of funding restrictions, but it can look at contracted out services and say, oh, people being treated appropriately in those services. So there's a great deal the NHS can do.
Yeah, thank you for that. Thank you for that. Can I bring it back to people with severe mental illness and learning disabilities and some of the issues relating to life expectancy for them? We know that there is a big gap in terms of expected life, quality of life and so on. Come back to your point that people often ask you the single thing you can do around this agenda. In that context, what would you recommend, I guess, as the sort of single couple of, well, maybe a couple of things that you would highlight as being important in terms of people that currently are on SMI registers, people with learning disabilities, how we could better support their health and better health outcomes?
Well, the first thing is recognition. And what's very clear, I mean, I've been arguing about social determinants of illness, and it's very clear that social determinants have a big impact as causes of mental illness. Less clear about disability. But what's also clear is that the presence of mental illness and disability mean that social determinants make your position much worse, whether it's employment, income, housing, all those things are worse. So the first thing we have to do, and again, I mentioned we're doing some work on cost of living in London, and it's very clear that particular groups at high risk are those with disability and long-term conditions, including mental illness. And so the first is recognition that there's an issue here, a real problem that, and it relates to my unfortunate phrase, proportionate universalism. I'm not going to get too many followers, unfortunately. I could have done better, I think. But we want universalist policies with effort proportionate to need, and people with disability and mental illness have particular needs. And we need to recognize that and put real effort. So my response is apply proportionate universalism, but that implies at the very first recognizing the particular needs of subgroups.
Thank you very much for that. Another question, it's a question of clarification, I think, really. Why do you think women in particular have poor outcomes?
Yeah, it's a very good question. And at first I ignored it when we did the 2020 report, because, you know, like all inconvenient facts, you know, as a scientist, if that doesn't fit with your view, you just kind of ignore it. So I was doing what scientists normally do, ignore inconvenient facts. And why was it inconvenient? Because in general, what we see is the effect of social inequalities are bigger for men than for women. We see in the East-West gap in Europe, you know, in Russia, for example, the life expectancy gap between Russia and the West is bigger for men than for women. In general, we see the inequalities bigger for men than for women. So when women seem to have suffered more in the decade from 2010, I thought it doesn't fit with my model, so I'll ignore it. Which is not a very good approach, I have to say. It was that then when I finally decided to wake up and pay some attention, and I think there's a fair case to be made that in excess of 2/3 of the impact of austerity fell on women. Because it fell on families, and that usually means women. And women are paid less than men. So the effect of austerity economically was affecting women more than men. And I think that is part of what was going on.
Thank you for that. Okay. The next question is coming from somebody who's interested in your view on the impact of climate change, on the impact of those suffering from inequality. And I suppose, again, you know, in terms of what can be done, what practical measures could be done locally, I guess, to support tackling that.
Well, I was asked by the Climate Change Committee last year to look at whether steps to improve health, or how steps to improve health could contribute to net zero greenhouse gas emissions. Because they asked me, I made it health equity. And we looked at 4 areas: transport, housing, work, and food. And air pollution is a big issue that cuts across many of those. And we said, be careful. If you don't take equity into account, you could increase health inequalities in your steps to achieve net zero. I mean, the crisis of fuel poverty, of course, hasn't been engineered to achieve net zero. It's a calamity of other causes. But just have a thought experiment. Imagine that it had been engineered to achieve net zero. Well, it's got a huge detrimental effect on health inequalities. So don't do that. Don't kill people to achieve net zero. Don't damage children's futures to achieve net zero. You've got to take inequalities into account. So, for example, a simple pricing mechanism tends to be regressive. It affects poor people more. Have that in mind. But you think of the 4 that we talked about. Transport, well, make transport cleaner. Public transport, cycling, walking. There's one, was it Waltham Forest? I'm trying to remember which area we're working in. I think it was Waltham Forest, had a proposal, the 15-minute proposal, the idea that people should be able to get to major amenities within 15 minutes at walk. So city planning to make transport cleaner, and that will have a positive impact on equity. Housing, well, I've already mentioned investing in home insulation, better insulation and ventilation. will contribute to net zero and will have a positive impact on health equity. Work. We've speculated about the 4-day week. Our productivity is appalling in Britain. It's 20% lower than in France. The French could go home Thursday night and have the same productivity as the UK. Well, let's think about productivity, and working 4 days a week would be good for the planet, good for work-life balance. Don't do it by reducing pay. Do it by increasing productivity. And food, meat is the worst from the point of view of contributing to greenhouse gas emissions. More plant-based food, fruit and vegetables, but they're expensive. Poor people can't afford them. Okay, we've got to look at the food supply to make sure that nutritious food is affordable. And then I said air pollution runs across the whole thing. If we reduce greenhouse gas emissions, we'll reduce air pollution. And I showed you briefly a slide showing poor children are more exposed to air pollution. Reduce air pollution, and that'll be good for greenhouse gas emissions and good for health equity. So let's get the evidence, let's analyze it, and we do it in the right way, we can achieve both these agendas together.
So Michael, thank you very much for your time this morning, and thank you for sharing your presentation with us. It's been thought-provoking, it's been stark. I think it sets some challenges for us as a system to reflect on, and no doubt, we will hear more from you, and you maybe from us actually, in terms of your.
We'd be delighted to work with you more closely.
Yeah, thank you very much.
Very good. Bye-bye.
Thank you. So next then this morning, we're going to get into the Humber North Yorkshire Showcase. We've got 3 presentations of about 20 minutes each, where colleagues are going to talk to us about some of the great work that's been going on locally across the ICB, and then we'll round off with another Q&A session. So keep the questions coming through the chat, please, and as people are speaking, if you can log your thoughts, then we'll capture those and we'll put them to the panel at the end of the session. So first off, we've got reducing perinatal and maternal mental health inequalities, and we've got Kate Morley and Elizabeth Adiki joining us this morning. So I'm going to hand over straight to Katie and to Elizabeth and ask you to take us through the next 20 minutes, reducing perinatal and maternal mental health inequalities. Thank you.
Thanks ever so much. I'm not really quite sure how we're going to follow that previous presentation, if I'm honest. I think Elizabeth and I will both say that we are a little bit nervous. I mean, what a stage to take. But thank you so much for giving us the opportunity to come along and speak to you today about what we're doing across the perinatal and the maternal mental health service to look at how we reduce health inequalities. Could I have the next slide, please? And the next one, sorry, thanks. So we just wanted to make you aware before we start our presentation that the content does include some distressing and potentially upsetting information regarding mothers and babies mortality and also other difficult themes. And also just to note that we do use the terms women and mothers throughout. However, we are aware that there are some people who do not identify as women who do give birth. These people are not excluded from this presentation. So I guess we just thought it was a great opportunity to come along today because we want to talk to you about some of the unique statistics that we find in the perinatal period. These statistics relate to our Black, Asian, young mothers and those from a disadvantaged background who live within our communities. These women are our family members, they're our friends, our service users, patients and colleagues. These women are not statistics, they're mothers. Next slide, please. So just to set the scene, across Humber and North Yorkshire ICB, there are 2 specialist perinatal mental health services, one covering Hull, East Riding, North and North East Lincolnshire, and the other specialist service covers North Yorkshire and York. Both of these services support women who have a moderate to severe or complex mental health problem during pregnancy and up to 1 year postnatally. We also have one maternal mental health service that covers the full ICB patch. This service supports women who have moderate, severe and complex mental health problems related to the loss of a baby, difficulties conceiving or separation at birth due to court proceedings. Next slide, please. So the Embrace report that we referenced this morning is a confidential inquiry into maternal deaths. This is the latest report that was only published last month. As I say, there are some shocking statistics that we are going to share with you today. So the report tells us that between 2018 and 2020, 518 women died during pregnancy or within the first year after having a baby, if the baby survived. Of these women, 229 died during pregnancy or within the first 6 weeks of delivery, and a further 289 women died between 6 weeks to a year after delivery. That's 518 deaths. Due to these deaths, it's left 366 children without a mother. The potential impact on these children is devastating and could impact on their development, have an impact on their education, their relationships, and also their mental health. We need to act. Unbelievably, Black women were 3.7 times more likely to die giving birth than the white counterparts. And Asian women were 1.8 times more likely to die giving birth. We are working closely with our local maternity system, who are working exceptionally hard to address these inequalities, which I'm sure you agree has to be a priority. Across our ICB, we know that we have some of the highest levels of deprivation in the country. The Embrace report states that women living in these areas are 2.5 times more likely to die, and this continues to increase year on year, which is just frightening. Sadly, 1 in 9 women who died had severe and multiple disadvantages, and we see a high proportion of women in our services who reflect these challenges. We have to make our services accessible. In 2020, women were 3 times more likely to die by suicide during or up to 6 weeks after the end of pregnancy compared to 2017 to 2019. And when I saw this statistic, it made me think about the impact that COVID really has had on our mums and the isolation that they'll have found themselves in. The report also makes us think about our younger mums. Under 24s made up 29% of deaths by suicide between 2018 and 2020, and are 25% more likely to experience perinatal mental health problems. This to me demonstrates how high risk this period of time is and how important the perinatal and the maternal mental health services are. 9 women died from COVID. However, if we exclude these deaths, 10.5 women died per 100,000 women giving birth, which is just devastating. And shockingly, psychiatric disorders and cardiovascular disorders are now responsible for the same number of maternal deaths in the UK. This fact demonstrates and emphasises the need for parity across mental health and physical health services. This message has to be shared. Next slide, please. So whilst Elizabeth and I were preparing this presentation for today, we also came across some additional inequalities that we wanted to share with you. So we know that the perinatal mental health and maternity workforce is not representative of the diverse population. Therefore, our knowledge of different communities, understanding of different faiths or cultural sensitivities can be really limited. That in itself is a barrier for women accessing our care. We know that diagnosis of schizophrenia in Black and Caribbean people is significantly higher than in white. And we also know that the outcomes for women with this diagnosis is poor, with their babies often being removed at birth. Black African women are 7 to 8 times more likely to be detained and hospitalised compared to the white counterparts. This cannot be right. And over 1/3 of domestic violence starts or gets worse in women who are pregnant. Within the service, we do have white ribbon champions, and we're lucky to have received some perinatal mental health specific training around domestic abuse within this period of time to help us have these conversations with our mothers. And then finally, we came across this study which showed that 40% of first and second year medical students believe that Black people's skin is thicker than white people's, and therefore were less likely to treat Black people's pain appropriately. So with all of this in mind, I'm going to hand you over to Dr. Elizabeth to look at the local picture, but also how we plan and what we are doing to tackle some of these inequalities that I've spoken about.
Thank you, Katie. Next slide, please. So just to paint the local picture briefly, we know that Humber and North Yorkshire is a multicultural area, and over the past years it's increased ethnic diversity has been quite a lot in areas such as York and Hull, which is fantastic to see. With regards to teenage mothers, Humber and North Yorkshire has a higher than national average, and what Katie said with regards to the outcomes for teenage mothers in the perinatal period is really quite poor. And additionally, we've got high numbers of asylum seekers in Humber and North Yorkshire fleeing war and conflict. Can I get the next slide, please? Thank you. So what are we doing about this? Health inequalities is a key priority for the ICS Perinatal and Maternal Mental Health Steering Group. We've got a joint task and finish group across perinatal and maternal mental health, prioritising women from Black, Asian and minority ethnic backgrounds and women living in more deprived areas. And this is due to the Embrace report that Katie has spoken about that has just highlighted such shocking figures for women who are in either of these groups or identify as being part of both of these groups. The group is working together to understand how our services can become more accessible and support changes, thinking about how we can make our services accessible to these women, making sure that we can go out to them rather than expecting them to come to us. Additionally, we've been joint working with the Maternity Voices Partnership Diversity Champion, which has been absolutely fantastic and invaluable. We've been able to link in with different charities and organisations that support ethnic minority women and their families across the patch, and think about what, hear their voices, hear what they think would be helpful for us to change within our services to make us more accessible. Can I get the next slide, please? Thank you. So with regards to the initiatives that we're currently working on, we are hoping to start a health inequalities facilitators group, which will look at gathering all of the leaders from our community groups, from our charities that support ethnic minority women and their families, and basically giving them information about our perinatal mental health services, our maternal mental health services, so that they can then disseminate that information to their communities in ways that they feel like would be helpful. But additionally, on top of that, so that they can come back to us and let us know what are the barriers, what do people like, what don't they like, what's helping, what isn't helping. We've just recently appointed a joint equity and equality post across mental health and local maternity systems, which is absolutely massive. I think it's going to be a great initiative to start thinking about how we think about equity and equality, both when that woman becomes pregnant in our maternity system, but then also, if she then goes on to need mental health support during that pregnancy, after that pregnancy, or if she unfortunately loses that baby. As part of the maternal mental health service, we have a peer support offer. At the moment, it's just located in Hull, and then we will roll it out across the patch once we get established. And at the moment, it's looking at supporting women from ethnic minority backgrounds. So this is again due to the Embrace report. We sent out a questionnaire to women asking what they think would be helpful with our new service that was starting, and majority of women came back and said that peer support was so important. They wanted to speak to women who had lived experience of baby loss, who could understand what they were going through, who could validate their emotions and break some of that stigma and taboo around baby loss. Additionally, we have set up, both in the perinatal team and the maternal mental health team, clinics within charities. This is linking in again, making sure that we're accessible, making sure that women don't have to go out and seek us out, making sure that we can meet them where they gather, where they feel comfortable and safe, rather than getting them into our office buildings, into a place where they feel uncomfortable. A lot of the women that we spoke to when we were doing scoping exercises and focus groups said that they didn't want family members to know that they were accessing a mental health service, so they wouldn't reach out due to that. So we thought, if we go to where they already attend every week, it breaks down some of those barriers already. Co-production work has been part of, from the very beginning of setting up the maternal mental health service and the perinatal mental health team. We've continued to work with women, continue to make sure that their voice is heard, continue to make sure that they are part of developing our services, so that it is accessible, so that they can, they feel like actually this is helpful, rather than us assuming what we think might be helpful for them. We are currently starting to develop some cultural sensitivities training across Yorkshire and Humber, which is going to be fantastic. We're doing a lot of work about going out, reaching out to women, which is great, but we also need to make sure that our staff are equipped for working with women from different ethnic backgrounds, so that women don't feel further traumatised whilst accessing our services. Like I mentioned before, we have a massive patch. We are really diverse, which is great, and I love to see that. But unfortunately, what we're finding is that the women that are coming into our services aren't representative of the cities that we live in. And unfortunately, the data capturing demographics has been quite poor. So our key priority at the moment as well is monitoring that data, making sure we're capturing the demographics of women, making sure that these initiatives that we're putting in place are actually making a difference. And if they're not, then going back to the drawing board to make sure that we're doing the things that need to be done for these women to access our services. We've also been able to link in with the universities, that's both psychology students at master's levels and the clinical doctorate levels, who have been researching barriers to accessing perinatal mental health services, looking at barriers to accessing services once they've experienced a miscarriage, looking at just the maternal experience whilst becoming a new mother, and we're hoping to use some of those findings to shape our services moving forward. We also would like to establish outreach clinics for asylum seekers within the area. We're hoping to roll that out next year. We think this is really important. Baby loss, maternal mental health, perinatal mental health difficulties does not discriminate. And for women who have come into the UK as an asylum seeker, already quite traumatised and vulnerable, we need to make sure that we are reaching out to them and that they know there's a service available to them. Lastly, we've been looking at the materials that we offer, so our posters, our leaflets, our website, making sure that they are available in different languages. With our website, the click of a button, making sure that our leaflets are being translated into different languages so that women can read them. We've had a really good focus group recently around the imagery of our posters and our leaflets, and we found that women have, for example, the maternal mental health service leaflet had like butterflies and flowers to represent baby loss. And women said, I would think that's a gardening leaflet. I wouldn't know what the service actually represented. They wanted to see women crying, holding a baby, so they could understand, if they can read the leaflet, they could understand, okay, it's a woman who's lost a baby, it's a woman who's with a baby and is struggling. I can then access that service. And additionally, women have spoken about wanting to make sure that there's both English and their first spoken language on the leaflets, as a lot of women are trying to learn English. So having both alongside each other, they would be more helpful than just having their first spoken language on a leaflet. So we're taking all of this great information and trying to implement it moving forward. Before I move on to my next slide, I just wanted to give a trigger warning that it will be a video of a woman speaking about her lived experience of baby loss. So if this content is triggering for you, I would just suggest that you take a step out, come back after the video's finished, and just look after yourself, really. So a bit of background about the video that we're going to be showing. It's a woman called Severine. She is the founder of Bora Shaba, which is a community charity group in Hull that supports asylum seeker and refugee women. She does fantastic work. She offers ESOL classes, cooking classes, sewing classes, hairdressing classes, and the premise behind her charity is to empower women, to give them a voice in a country, in a system that they perhaps feel voiceless in. So I'm going to stop speaking. We're going to share the video to end of her experience of baby loss. Thank you.
Came in 2006, and I wasn't trying to have a baby because I had already 3 children. So I was okay, but there was that feeling that I wanted to have a baby. Yeah, so I tried 2014, had a miscarriage, and 2015 had another miscarriage. So when I stopped feeling the symptoms, I was worried and concerned. And I could remember what happened with my previous pregnancy, because I had 2 months miscarriage. So then there we are again. So I was so stressed, but I didn't really know what was happening. I go to work, but I couldn't stay for half an hour. And because we're just near the hospital, I went straight to the hospital, and I was heavily bleeding. And so I did just understand that that was the miscarriage. We don't really talk about miscarriages or stillbirth and stuff in our culture. So when you're pregnant, you don't even tell your parents, don't tell anyone else until maybe they see, if you meet, they'll see that, you know, the belly's out. Lots of women have gone through those situations and experiencing a lot of challenges that was related to culture, religion, and barriers. You don't talk about, you keep quiet, you suffer in silence. And when you have that miscarriage, you won't have that, you know, opportunity or just the courage to talk to anyone. Back home, we do talk to our aunties, we talk to our grandma, but here we don't have anyone to talk to. We don't have grandparents here. Because there wasn't any support, there wasn't any, I didn't know about any services at all. So I didn't do anything at all. If I knew, I could have written down some things, you know, when I lost the baby and stuff, but I don't have anything at all. It's so hard, and we do experience stress, trauma, which we do develop in, you know, mental health, because we just keep to ourselves. For me and the people that I support, the main thing is about language, because you may have, you know, some difficulties, you may have some problems, but who do you talk to? Don't know. You don't have that access because the language barrier. If they have maybe somebody who can help them to express themselves, somebody who has the courage to talk about things, I think that will save lots of lives. For me today, standing here, my message is to tell women that you are not alone. their services. The maternal mental health support is here for everyone, and I will encourage everybody to go for that help. People are ready to help.
Thank you.
Thank you very much, Katie and Elizabeth. Extremely moving ending to your presentation there, and a really helpful overview of the really important work you're doing around making your services more accessible to all members of our communities. So thank you very much. I'm hoping that people are going to be putting some questions in for you to pick up in the panel. So if you've got any thoughts, comments, questions that you want to raise with Katie and Elizabeth, then get them into the chat. So now we're going to hand over to Gail Teasdale. Some of you will know Gail, who's going to talk to us about reducing inequalities and improving outcomes for children and young people, and talking about the trauma-informed work that's been going on in the ICB. I think you're going to also be showing a video with Katie, joining by video. So,
yes,
Gail.
Initially, Katie couldn't be here today because she's actually running some training on trauma-informed system change for senior leaders in North Lincolnshire. So we've got a pre-record from Katie, and then I'll follow up with information about what we've been doing locally. So over to you then, if you want to get that started. Yeah, so Katie Taunt is... Good morning. Katie Taunt is a national trainer for the ARC model around trauma-informed care, and she's also presented around the world on this, and she's running our local training at the moment to help with our strategy. So I'll hand over to Katie.
So good morning. I'm sorry I'm not with you today in person. I'm actually up in Scunthorpe, carrying on with the wonderful work of the project that I'm involved in up here. So my name is Katie Taunt. I'm a trainer and consultant and therapist. I'm the licensed ARC trainer for Europe. And in this context, I'm working with the wonderful Humber and North Yorkshire Vanguard project, where we're setting up an integrated framework of care for vulnerable young people, and this is particularly with a view for young people who are at risk of becoming involved or escalating through the criminal justice system. And I believe my brief today, so let's hope I get it right, is to give you a little overview of what we're talking about with trauma, talk about what we're understanding as trauma-informed practice with the help of the UK government, and also to tell you a little bit about the map that we're using. So trauma-informed practice is what we're doing, and what we're using as a map is the ARC framework, which I will tell you about at the end of my 10 minutes. So first of all, the thing we need to do is establish what we're talking about by trauma. People typically think of trauma as post-traumatic stress disorder, PTSD. You may hear people talk about big T traumas, big life events that completely alter the way people function, with flashbacks and avoidance and change in how they're functioning. But we're talking increasingly about something you might call small T traumas, which is that constant ongoing assault on a person's development because it's relentless. And we'll talk about what those are in just a minute. We can't talk about trauma without talking about Bessel van der Kolk, who's very much behind developmental trauma or complex PTSD being understood in the context of psychiatry and wider practice. I'm a bit of a trauma geek, and this is my favourite trauma quote because I think it really captures it. He says, "We have learned that trauma is not just an event that took place sometime in the past. It is the imprint left by that experience on mind, brain and body. And this imprint has ongoing consequence for how the human organism manages to survive in the present. Trauma results in a fundamental reorganisation of the way mind and brain manage perception. It changes not only how we think and what we think about, but our very capacity to think." I tend to think about trauma as being the survival response turned on and not processed or not held. Think about all the things that might have happened to a young person that meant they shifted from getting on with their life to being in survival, getting ready to fight, to freeze, to flee. Some of those big events, some of those small events, like living in places where you don't feel safe with adults who aren't responding to your needs. Another quote, and we're moving away from this idea that trying to tell people, you know, the typical let's just have a word with. Why doesn't that work? Well, it doesn't work because we need the thinking part of the brain to be engaged. And so many of the actions are coming from the downstairs brain. It says psychologists, but actually I'd say all of us usually try to help people use insight and understanding to manage their behaviour. However, neuroscience research that shows that very few psychological problems are the results of defects in understanding. Most originate in pressures from deeper regions of the brain that drive our perception and attention. When the alarm bell of the emotional brain keeps signalling that you are in danger, no amount of insight will change it. Now, actually, I suppose I want to just qualify that in the fact that for many of us, that is enough. For many people, it is enough just to know that if you do this, something bad will happen. But the young people that we're talking about are the young people whose brains work differently because of complex trauma, which means they know what the consequences might be. They know why it's a bad idea, but their behaviour is driven by fear and survival responses. Many of you will have heard of the Adverse Childhood Experience study. This was the work of Vincent Felitti and his colleagues in California in the 1990s. And they looked at 5 particular types of adversity and looked at the impact long-term of having experienced adversity in childhood. I'm also imagining a bunch of you kind of also sort of shouting out about the fact that this study has had many criticisms and many challenges. I think the important thing to think about it is that Vincent Felitti and colleagues started it. Absolutely right, they missed out racism. They missed out the trauma of exclusion. They missed out the trauma of poor housing. They missed out so many things that have the potential to traumatise, and their cohort was white and middle class. But if you hear Vincent Felitti speak, he never meant us to start scoring, you know, 0 to 5. Instead, we're working with practitioners to just keep in mind all of the things that might have impact. Have we thought about them? Have we asked about them in an attuned way in the context of a trustworthy relationship? So Bellis repeated the studies in 2016, and his nice summary really is that the theory that's underlying the ACEs is that these early traumatic experience alter brain development and the development of hormonal, nervous and immunological systems. But we don't want to think about just kind of locating it as a problem located in the child or the young person. We need to broaden our gaze. We need to think about intergenerational trauma. We need to think about racialized trauma. We need to think about community trauma. What's happening? What's the environment in which this child or young person is growing? And how is that impacting their capacity to be present? So children and young people with trauma present with a lot of symptoms. You know, we could have an interesting conversation about how symptoms we see as ADHD might be the consequence of trauma. How this poor control of emotions, inconsistent academic performance, children who are unpredictable or impulsive, children who overreact to things, or young people who respond suddenly for no reason. It came from nowhere because something happened that reminded them of their traumatic experience. They may be aggressive to people they think are in their space, and they may struggle with authority and really struggle with change. Much of this is the lower brain experiencing something that's unsafe and responding in a way to keep themselves safe. If you think about our young people, young brains born into the world, that there are kind of 2 main drives. The first is to survive, The second is to develop and grow. If the circumstances allow it, then we have space for making friends, learning how to hold pencils, sitting still in class. If not, we're going to put all of our energy into survival. And when the survival brain is switched on, there's not much space for development. So we have a bunch of young people who are absolutely wonderful at reading dangerous situations, at reacting fast, of having their attention in lots of different places, of reading aggression or violence in somebody's face, but less good at others. So they've got skills. They're just not the ones that fit particularly well with the world that we live in, or certainly the school environment that they attend. So we use our trauma lens to work out how children and young people who've experienced trauma make sense. They had to live with too much danger and not enough attention to basic needs. And there are therefore two primary functions of their behaviour: getting their needs met or avoiding danger. I'm not going to spend all of my 10 minutes reading you this. I'm going to whiz through this piece. There have been various working definitions of trauma-informed practice coming out of national trauma networks in Australia and in the States. And let's work with the one the UK government has given us. They are recognising that trauma means we realise that trauma can affect individuals, groups and communities. That we recognise the signs, symptoms and widespread impact of trauma. That we work to prevent re-traumatisation. And I've highlighted this little passage because as I'm training people, often we're wondering whether I'm trying to turn everybody into a clinician like myself to work directly with therapy. And it's not about that. It's about helping everybody that's working with young people and adults and children where there's a history of trauma, creating environments that feel safe, so that we can form relationships and do the work that needs to be done. The 6 key principles of trauma-informed practice: safety. It's number 1. We want people to step into our services, into our relationships, and their nervous systems go, yeah, I'm safe here. We want to be trustworthy, because if we're trustworthy, then people feel safe and we can do our work. We want to have choice. So that we can work together to help people work out what they need to get their lives back on track, to work together collaboratively and to empower those that have been disempowered to be able to be available and engage in life in a way that works for them. And we've got to have this cultural consideration as well, because racism in particular continues to be a trauma for children and young people, through systemic racism and through discrete acts of violence. If systemic racism in our education system, in our policing services, in our youth services, mean that our young people, our Black young people, our young people of colour do not feel safe, they cannot learn, they cannot connect. In trauma-informed practice in the youth justice system, there are many bits of research out there linking trauma-informed practice to youth justice work. But we're really trying to help that the consideration of the child's social, emotional, and developmental life course means that we can make reasonable sentencing guidelines, that we can look at the interventions that are needed so that our practice allows us to address and make sense of how this behaviour came about. Trauma-informed practice. We understand a whole range of behaviours as the adaptation that the young person needed to make in order to survive. We ask what need is being met or what danger is being avoided by this behaviour. We ask what happened to you, not what's wrong with you. And we ask, what do the adults in the system need to be the people our young person needs us to be? And how can we resource them so they can learn to regulate and manage themselves when we're not there? Not clamping down, managing their behaviour, but resourcing them to be able to regulate. We don't see our children and young people as just manipulative, attention-seeking or destructive. They're just trying to cope using any resource. Of course they are manipulative and they do need our attention and they can be destructive. That's the symptom, not what it is. A nice piece of research, again, reminding us we've got to address bias and prejudice within services, and we can't look at any service without that. The reason that we've chosen the ARC framework is that we really want to pay attention to the whole context and the system, and not just start where worker meets young person. A nice piece of study here says that moving beyond the professional young person dynamic to consider the young people and others in their lives, particularly their families. Relationships with families and communities are crucial when considering a youth justice approach. We're moving from kids do well when they can, away from a kids do well when they want to. Our traumatised young people don't make choices, they react. So that leaves me a very short time to tell you about the ARC framework. This is the ARC framework. It's the work of Margaret Blaustein and Christine Kinneberg, and came out of the Boston Trauma Centre in response to Bessel van der Kolk's work around how do we support children and families with complex trauma? How do we help them get back on track? We have 3 strategies in everything that we need to do. Is this family young person engaged with us? We share our knowledge. Kids aren't going crazy. This is what's going on for you. This is how it works, that you're reacting when you're frightened or scared. We help support with routines and rhythms and predictability, both in their homes and in our work, because that makes young people feel safe. Then we start off with creating a relationship that allows us to work with children, young people and families. That means, first of all, supporting their adults to be able to manage their own stuff and not take it personally, and for us too. We teach adults, and we do it ourselves, to attune, to make meaning out of a child's behaviour. Only then can we be effective in the way in which we respond. This, for me, is the beauty of the framework. We can't do one thing without the other. We often get asked to do competency work when all of the foundations are wobbly. Improve this child's peer relationships when they don't trust anyone. We then help young people learn to regulate, to first identify what they're feeling, then give them the skills for down-regulating or up-regulating as needed. If they can do that, we can help young people work out who to communicate with, which adults to build relationships, how to do that. We work to improve executive functions, a set of skills that never got developed when they were busy surviving. And finally, a real positive sense of who they are and where they're going. So often the work starts with, can you start with building their family relationships back up? Well, not if they don't trust us. We don't understand how they make sense. We can't respond effectively and they can't regulate. We have to do that first. This is a map. This says, first things first. Favourite slides ever. When a flower doesn't bloom, you fix the environment in which it grows, not the flower. It's a both and approach, working directly with the young person, but making sure we have resilient adults and resilient communities to support our young people. Thank you for your time. I hope I haven't taken too much of Gail's. I wish I could be with you today. Please take care.
Thank you. So very briefly, I'm just going to say a little bit about what we're doing in Humber and North Yorkshire, and people are welcome to contact me after the conference because I could have done a whole hour just on this, but we're trying to cover that whole life course. Next slide, please. And I think it's really important when we talk about the best start in life for children, and I'm not taking away from any of the issues around maternity, but the best start in life for some children can start at any point in their childhood. So it's really important we think about those school years as well as early years and maternity. And what we're trying to do across Humber and North Yorkshire, we're one of 10 programmes across the country who were successful in securing additional funding for a 10-year programme working around how we deliver this system change. So instead of expecting young people who've experienced trauma to change to fit the system, we are changing the system to meet the needs of those children and young people. And I think it's really important that we're able to secure this additional funding. As we know, only about 7% of national funding for children's mental national funding for mental health is going on children and young people. So we talk about the best start in life, but quite often we don't always have that capacity to do it. So this is a really exciting opportunity. So what we've been looking at in our programme, which is working across all 6 places, is we've been scoping out very much where places are and what they're already doing, because this is about building on existing work and working with partners where they are in that journey to being trauma informed, about building an integrated care system across our ICS, so we don't have organisational or geographical boundaries which impact on the support children receive, and really strengthening our multi-agency relationships, and testing new models of intervention in some of our place-based provision. Next slide, please. So when we talk about trauma-informed and system change, we want to support organisations to move from being trauma-aware, because awareness is important, but actually it's got to be more than that. And it's about understanding how organisations can actually re-traumatise children as well. So we want organisations to be supported to move through the system from trauma aware through to trauma informed. Next slide, please. And while we are trying to prevent children and young people from ending up in the criminal justice system, we know there's a whole range of experiences those children have had before they come to that point. So they may have experienced living with abuse and violence, being part of established crime families, victims of county lines, child sexual exploitation, criminal exploitation, or had drug and alcohol issues in the family. And it's really important we think about that whole family approach. Because quite often sometimes we're seeing 2nd and 3rd generation trauma, so we need to make sure the parents and carers and family are supported too. Next slide, please. So what we're trying to do is make sure that we embed our approach using the ARC model, which Katie mentioned, but also in parallel working to implement AMBIT, which is around how we support our staff and some of the trauma they may have experienced, so that staff feel confident and able to support our vulnerable young people, and embedding that in the Thrive model for our children's mental health, from early intervention and prevention right through to clinical care and crisis. Next slide, please. So when we talk about our stakeholders, it's really important that the focus isn't just on mental health services. As Katie mentioned, we ask young people to sit and tell us about what their problems are, but if we don't build that trust and if they don't get consistency across the whole range of services in their lives, they learn to mistrust agencies. So it has to be mental health for a key part of it, but it also has to be wider services, including our voluntary and community sector, our local authority services, including youth services, youth justice, early help and social care, and also education. Children, we hope, spend a lot of time in schools, and it's important that our schools are supportive. And while we're trying to change the system locally, we've also trying to make sure that we support national partners in that. So only last week we met with the Department of Education to look at how we can work with them to ensure behaviour policies in schools are trauma informed. So we're doing that through a whole range of training for partners, including 2-day training for frontline practitioners, developing champions in our organisations who can embed it in induction, AMBIT, which I mentioned, and also a leadership model to make sure those senior leaders in our organisations are able to support organisational change. Next slide, please. And we're developing communities of practice to bring together organisations to share learning, but also share challenges and how we find solutions. And we have a trauma-informed toolkit, which has been developed to support organisations to self-assess where they are on that journey to being trauma-informed and identified where additional support may be needed. Next slide, please. We have 3 test and learns, and just in a moment you're going to hear a minute-long film from one of them, which is the Warren and Corner House, who are delivering Flipside, and this is about direct diversionary support for children and young people at risk of entering criminal justice, taking that trauma-informed approach. Next slide, please. We also have in North East Lincolnshire the Jeff project. These services have been named by young people. And next slide, please. And in North Yorkshire, we also have a test and learn pilot. And all of these are working with voluntary sector, youth justice services and health to try different ways of supporting these vulnerable young people. So just to finish off, I'm going to hand over to our very short film from the Warren, so you can hear direct from them the difference that this programme is making. And if people want more information after the conference, they can contact me.
The Warren are working together with Corner House, which is another voluntary community sector organisation in Hull, and we've come together to work on this project, which we've called Flipside, and that was decided upon by young people themselves, and it's an early intervention project that helps 11 to 19-year-olds stay out of the criminal justice system, to avoid sexual and criminal exploitation, and to use holistic ways and creative ways to express themselves, to help their mental health, and to hopefully help them make better choices.
This one was completely different in terms of we put forward a proposal and actually we were given the service because obviously it came from our ideas and our proposal. So I think that was very positive. I think the meetings as a whole are very partnership orientated. So as a voluntary community sector, it's nice to be listened to and heard, but also feels that we can make a difference within those meetings. So we're not treated as some lower class organisation because we're voluntary community sector. So I think it feels very powerful. The communication is great. We know there's loads of people we could just contact if we've got any queries. We get immediate responses, and they're very supportive, and they want this to work as much as we want it to work.
Having this project is a massive deal. We've tried to incorporate, which we do anyway, we try to incorporate young people's voice throughout, and we have done that setting up this project, and hopefully going forward we will continue to do that.
So thank you very much, Gail. Thanks for taking us through that presentation and showing us the video from Katie. We are a little bit behind schedule now, but I am going to ask Lucy Chiddick and Paula Ashton to now just take us through the work that they've been doing around homelessness. So over to you both.
Thank you very much. So we are delighted to be able to share with you some of the brilliant work that Paula's team are doing in the system. If we could have the slide set up, please. That's okay. Brilliant. Okay. So in about 5 minutes or so, Paula Ashton, clinical lead of the homeless mental health team, is going to take us through some of the fantastic work they're doing. And I'm just going to talk to you very briefly about why inclusion matters in this context. Can we move to the first slide, please? Thank you. Now, quite honestly, I could not have been preceded by more formidable presentations. I feel like I'm sitting here talking about inclusion and deprivation and mortality rates and standing on the shoulders of an extremely high giant of Sir Michael Marmot. Well, he well articulated the connection between the most deprived communities and the appalling mortality rates that they experience. Let me just take that one step further. Excluded groups, look at the end bit of that curve and the mortality rate of the most excluded groups. It's exponentially high. People experiencing homelessness, one of the subgroups that Sir Michael Marmot referred to, have an average mortality age of 45 to 47 years old, 45 to 47 years old. Which is absolutely unimaginable and shocking, quite frankly, in this day and age. Move to the next slide, please. Again, preceded again by a most fantastic speaker, Katie Taunt. Thank you for outlining the issues that are the fundamental issues of the ACEs study, but also the what it showed us. It showed us some really significant things. So it was flawed in many ways, yes, but it showed us some really, really important facts. And they are that trauma without any protective factors, trauma leads to a high allostatic load, that constant toxic stress on the body, which leads to increased risk of heart disease, stroke, depression, anxiety, diabetes, a high burden of disease. Now, people experiencing homelessness across our region have a high allostatic load, high burden of disease. So they should have fantastic service provision, right? There should be targeted funding and fantastic, cohesive, coherent provision across our region. Unfortunately, services built on a dominant narrative. And a dominant narrative is that with which we, through our own lens, through our own experience, design our service provision, which speaks to the middle of the bell curve. So unfortunately, people experiencing homelessness across our region don't experience, in every area, don't always experience equitable access to services. But there's some fantastic pockets of work going on which enable them to experience services and have a completely different experience of healthcare. And that's what we're going to highlight today. Can we move to the next slide, please? Okay, so we talked about the link between, one of the questions Sir Michael Marmot sort of answered earlier was that link between NHS, what is in the role of the NHS? And we've got to consider when we're thinking about adverse childhood experiences, the adverse environments. They matter. They contribute to the toxic stress and high burden of disease that people experience, particularly those experiencing homelessness, right? So it's absolutely imperative that we recognise the high prevalence and negative impacts of trauma and address them in the healthcare services. Or we as professionals who experience stress, we experience burnout, stress with what we see every day, and burnout and stress in terms of our own capacity and workforce issues, but also what we see as negative consequences for our patients. So we need to work and look at our service provision through a trauma-informed lens, and how fantastically articulated that was in the presentation before us. Brilliant, couldn't have said it better, so I'm not going to. Can we move to the next slide, please? Protective factors matter. They really, really matter. And this is a lovely slide which sort of sums it up, and it looks at those protective factors that we can put in place throughout a person's life, which can help and heal those adverse experiences. They don't lead to traumas, they don't lead to toxic stress, they don't lead to a high burden of disease, right? Kind of just makes sense, doesn't it? So we need to look at this through the lens, through our healthcare provision, don't we? We need to look at this through our service provision. And this is how it all interconnects together with health equity, right? Can we go on to the next slide, please? So what we're doing in Hull, this is why Paula and I are here. There's so much going on, and there's so much I could talk you through. But one of the things we're looking at is we've got a programme of work called Changing Futures, funded by DLO. And in Changing Futures, the Changing Futures programme was set up to recognise that people fall through the gaps of services and systems, making it harder to address problems, which lead to negative consequences, well-being, and those of future life chances. It recognises the needs of the subgroups that Sir Michael Marmot referred to. Okay. And there's a huge programme of work. And when we talk about groups of populations, I sort of hate boxing off people into categories and things. They are our population, our people, they're our neighbours, they're people in our communities. But just for ease, just so you understand who we're referring to, it's for people who are experiencing homelessness, people who may use substances, people who are experiencing trauma in contact with the criminal justice system with poor mental ill health, 2 or more of those factors, people experiencing severe and multiple disadvantage. But there are people in our communities, they're our neighbours, they might be our friends. And we need to recognise that when we're thinking about service provision. Okay, so move to the next slide, please. Huge programme of work, which I won't go into now, recognising that we're short of time. Don't stress, Ben, we're going to keep moving. So, but it's and just move to the next slide, please. You can have a look at that through your own time because slides will be shared. But it's 2 things I just want to draw your attention to. And one is the work of lived experience. It's so vital that our work that we do is person-centred and driven by people who are using services. And we recognise that, and we want to work with people to drive that forward and to hear, understand, and collectively work together to change our systems. So that's really key part of the work. And the other, please move to the next slide, which is really exciting. And I'm going to take my time just to talk through these next 2 slides, then we'll lead on to Paula. We are journeying towards becoming a trauma-informed city. We are journeying towards becoming a trauma-informed city. We're at the very beginning of this journey. It's about system and culture change. It's about compassionate leadership. Now, this should be embedded throughout all we do, right? Compassionate leadership, system and culture change. We've got a programme of work that's looking at doing this over the next few years. This is going to be a journey. This is not, we are a trauma-informed city. We are on a journey. We're journeying together and we're going to collectively do this together. We had our first steering group. We might not call it a steering group. It might be something completely different, but people need to design the name of this group. But we had our first steering group, as it's called at the moment, meeting. Had around 40 professionals working across the public and voluntary sectors, that people with lived experience of trauma, community leaders, community members, and many of our strategic leaders from hospital, probation, public health, social care, health and care partnership, came together over a shared vision. Can we move to the next slide, please? And as part of this journey, there's a whole host of work, but I've just outlined a couple of key things: lived experience, training, working with Gail's team, but working with education, children's services, adult social care, and we're embedding. We've got a programme of training to embed as part of our Changing Futures work, and we're working in that collectively together to make sure we don't overlap, but we fill any gaps. And we are looking at embedding psychologically informed environments across the system. We've got a consultant psychologist with us who's got expertise in this, and we have a full-time psychologist attached to the Changing Futures work, which Paula will refer to later. And I just wanted to highlight a beautiful piece of artwork that our Lived Experience Collective have undertaken within one of our environments in the city centre. So if we just move to the next slide, please. Why does inclusion matter? It matters because the reality we're in is the first bit of the slide. We talk about healthcare equalities. Well, equality doesn't quite cut it, does it? Equity, we're almost getting there. Liberation is the true vision. And I want to end on a quote from Jane McGonigal's book, Imaginable, about urgent optimism. Do you know, I don't know about you, but I listened to Sir Michael Marmot's talk and he's so inspiring. And we just look at our system and think, gosh, what can we do? What can we do? And I just want to hold on to this quote and share it with you. Urgent optimism. This is how I felt when I listened to the speech. Desire to act immediately, to tackle an obstacle, combined with the belief that we have a reasonable hope of success. It acknowledges there are challenges, but there is an understanding that we collectively have the strategies and skills to overcome them and create our own future. Urgent optimism, guys. So I'm just going to pass over to Paula, who's going to talk you through what urgent optimism can do in your area. Thank you.
Thank you, Lucy. So I'm Paula Ashton. I'm the clinical lead of the homeless mental health team. And this whole programme today really has been talking about inequality amongst groups of individuals, including for our team, inequality among homelessness. In particular, what's really sort of striking to me is how prevalent mental health difficulties are amongst people who experience homelessness. Different statistics over time have shown that perhaps half of the people who are experiencing homelessness have an experience of mental health difficulties, and how 42% of those people, of that group of people, have both mental health difficulties and substance misuse issues. It's really prevalent amongst a group of people. There was a recent study that came out. Oh, sorry, can we move on to the next slide? Sorry. Some of the statistics that are in there have already been discussed on or referred to from those speakers that have been spoken previously, but one thing that recently has really hit home to me is a study from the Newcastle University that found that 94% of people who are experiencing or facing homelessness have a history of trauma, and that 2/3 of that group of people have a history of 4 or more traumatic events within their lifetime. When you look at how that group of traumatized individuals are living in an environment that is least conducive or least likely to lead to recovery, it's a really significant figure, and it highlights the importance of the trauma-informed approach, trauma-informed care approach that's already been discussed. There's many barriers to homeless people accessing mental health services. There's the stigma that a lot of people experience, stigma and discrimination, difficulty in trusting services, perhaps a history of toxic help from mental health services, or the times when they may have been approached by a mental health service, or perhaps a mental health assessment, they may have felt re-traumatized by that. So lots of different barriers regarding the homeless population. Can we have the next slide, please? So in 2022, we were commissioned with 5-year funding from NHS England and from the local authority in Hull. And that was to provide a barrierless homeless mental health services to people who are experiencing homelessness in Hull or at risk of homelessness. That would cover people who are living on the streets and also those who are in the hostels from an age of 16 onwards. It also covers sofa surfers and what was often described as the hidden homeless. And as you can imagine, that's a very large ask of a small team. If you go to the next slide. So the team is small. Up until the recent Change in Futures funding, which Lucy's already referred to, the team consisted of myself as clinical lead, a clinical psychologist, 2 Band 6 professionals, some time from a psychiatrist, and 1.5 healthcare assistants. There is also a different arm to the team which provides and looks at trying to prevent homelessness for people who perhaps might be socially excluded or at risk of hoarding. And that's a different arm of the team, but this time we're just talking really about the rough sleeping and the homelessness. So if we can move on, please. So we found, first of all, that we started this project at a time when COVID came in. So it was quite difficult for us to navigate the different systems. Hull City Council had already set up an assessment hub model, which was really good at being able to work in partnership with all the different agencies. So for instance, when you talk about barriers for people accessing for the health inequalities, when a person was homeless and they accepted to come into the hub, there would be all the different professionals and agencies around that individual. So within the period that they were in the hub, there could be health services, for instance, in mental health, there would be physical health, addiction services, housing services. So really trying to work around that individual. And over time, that model has changed slightly, as things do, because of different funding and the different events that COVID brought. But what really has grown from that model on the early development is about working together across the partnership agencies, how we actively reduce and the barriers that the homeless person might experience in trying to move on in their life. We also had to decide how we would prioritise who we would work with. As we said before, it's a huge cohort of people in Hull, and how do we decide who we could work with? We really narrowed it down to the people who would ordinarily fall out of services. So the ones who are unable to keep appointments, who perhaps live the lifestyles that would be described as complex, of multiple disadvantage, how we identified that what really our prime intervention with people is to develop relationships built on trust. We looked at how we would do that. We were one of the first homeless teams that was commissioned across England and the UK, and so we looked to our peers who were already providing that service and sought their advice as to what evidence base is there for working with people who have experienced homelessness and the high level of trauma that's experienced. And we've adopted the approach of a pre-treatment approach, which is about establishing a relationship initially, and a relationship that's built up on trust, and how even in the very early stages of building that relationship, there are steps to that, how it can be often even just being in a person's presence for a brief period of time, until that person can observe you, can see that you're trustworthy. They may even be approaching people, but obviously they'd be aware that you were from mental health services, but it would be about offering something practical, something in the here and now that would help that individual, so that you can help to build trust and relationship with them. My colleague, Dr. Dan Southall, reached out to the other psychologists who were providing this service across the UK, and he's been instrumental in setting up a monthly forum called Setting Up Services, which has been really useful in helping ourselves develop as a service, but also helping the other homeless teams that are being developed or becoming established in ways of working with people. Can we move on to the next slide, please? So we have various different ways of working within homelessness in Hull. One of the things that we do is outreach. So in order to be barrierless, we reduce the need for people to come to see us, because we just know it wouldn't happen within this population group. And so we'll go out in the mornings and go to breakfast clubs or soup kitchens. We quickly identified that there were areas where people would go for warmth and to meet their basic needs that we could just be present at, so that people would become used to our faces. It would be easier to approach us and for us to approach them. So for quite a while now, we've been going to the breakfast clubs and just serving the coffee, perhaps having the logo of the homeless the NHS on our badge, which would strike up a conversation. So then we'd, whilst a person is street homeless and out there, it's very much about trying to maintain that person's safety as well. So although the person may say, oh yeah, I've got mental health problems or things that have been happening to me, it's about saying to them and helping them to build that relationship with you whilst keeping them safe and avoiding that re-traumatization of talking about the trauma that they may have had or the history that they may have had. We often found at first as well that actually our work generated an increase in assessments under the Mental Health Act. And there were some people who were on the street where it was clear that their reluctance to seek shelter was based upon a delusional belief, and that needed further assessment. And that in itself was about the whole team developing, including this service that provides the mental health intervention and assessment. We developed an arm where we can do a self-referral, where we do drop-ins in hostels and also out in the community, so that people can come to us in bite sizes and take from us and build that relationship as they want on their terms and in a trauma-informed way, so gently building up a relationship built upon trust. And a person can come and see us in a hostel once, and we perhaps might not see them again for a couple of months or a couple of weeks, but that they can come back and build up again from where they were on that initial stage. We also have the next pathway, where if a person we are able to build up some form of relationship, that we take that person on a one-to-one support. So able to see them outside of the hostel and to be consistent in things like offering appointments and being present and available and building up that trust and relationship. We also have another arm to the service where we find that there are people who are experiencing homelessness and who perhaps might be frequently at Hull Royal Infirmary, for instance, or frequently coming up to the notice of crisis teams, but who actively do not want any mental health support, but yet can be turning, perhaps out on the streets still and refusing to come in to anywhere warm to help to meet their needs. And we developed a pathway where we're able to work with those individuals, with the services surrounding those individuals, to be able to offer the service support about working in a trauma-informed way. So we would look at doing consultation and formulation with our partner agencies as well, to be able to gain an understanding of that person's history, why they present with the issues that they present with, and how we can work with the individual in a trauma-informed way, how we can do the building bricks of building a relationship. And we recognise that sometimes, and quite often, it's not us as mental health services that would be able to do that, but that we can help and build the strength in the system, so that whoever has that relationship with that individual, perhaps it's somebody from addiction services or somebody from the housing services, that we can nurture that relationship and help that individual gain the confidence in working in that trauma-informed way. So really informing the system to work in a trauma-informed way. Can we go to the next slide, please? Just wanted to highlight an example of Matty, because I think it really touches upon all the different elements that I've just discussed. So Matty is a 40-year-old male who first came known to us when he attended a breakfast coffee morning out on the street around about 8 o'clock in the morning. It was September 21 and he'd just been recently released from prison. He has a long history of homelessness, in and out of homelessness, roughly from the age of 20. And prior to that, he had a history of quite a traumatic upbringing. The details of that he's never really disclosed to us, but sort of always alluded to something in his past which had been very traumatic. He'd been in and out of employment at some points during his life, and also had quite a long history of in the justice system, so in and out of prison for a fray or GBH or things like that. So we came to...
Paula, sorry to interrupt you. I'm just conscious of time. Really interested in hearing in Matty's journey. I'm thinking we're probably going to have to draw it to a close in about 2 minutes or so. I'm really sorry to cut across you, but just to let you know, that's where we're at. Thank you.
So we started to build a relationship up with him whilst he was street homeless. He was street homeless for roughly 3 months without any benefits in place, because he wasn't able to claim the benefits due to being homeless and the difficult practicalities of that. He eventually moved into his own home and his own housing, and it was only at that point that we were really able to develop that relationship further with him. We recognised that when people move into their own properties, that actually that period, or that transition period, is also a significant risk period for people who are coming out of homelessness, because of the pressures that they experience on maintaining a tenancy, on being able to come out of that survival mode and into that more reflective mode, and actually the impact of trauma being more significant on them. As a team, we were able to develop a relationship with him, and over time, through the use of going out for coffees, for even going out playing snooker with him, was able to build a relationship up with him, where he could, for a period of time, see that he could reduce, or actually had a chance of being able to have a life that would move out of that homelessness that he was in. Unfortunately, I'm trying to rush this now, and I'm probably missing out loads, but unfortunately, he was he had to answer us with the police at something that had happened 12 months previously, and it kind of acted as a bit of a trigger for him, and he was eventually recalled back into prison. But whilst he was in prison, the team have been able to maintain a relationship with him, in the knowledge that actually when he comes out, we can pick back up again from where we were as a team, and to be able to help him. Because one of the things that we look at is a consistency of worker, about the fact that working with people who are experiencing homelessness, there may be gaps in the service that we provide, in the timeframes that we provide that in, but that it follows that person through their journey in life. So next next slide, please.
Thank you very much, Paul. I'm afraid we're going to have to draw it to a conclusion. Thank you very much. But I think we've got a really good feel for your service, and I'm sure if anyone's got any further questions, they'll contact you afterwards. We're just running out of time, I'm afraid, so we're really sorry to cut you short. We are coming to the end of the session today. I just want to say a big thank you to Lucy and to Paula for their contribution this morning. Also to Katie and Elizabeth and Gail. I'm going to hand straight over to Michelle now, just for the closing remarks. and we'll draw this morning's conference to a close. Michelle, over to you for the last few words.
Yeah, thanks, Ben. Thank you, everybody, for your presentations in this second part. They've been really powerful. I think starting off with Sir Michael Marmot was absolutely powerful. I think that's followed through. There's lots of questions about trauma-informed care, and we are taking it forward in the ICB in relationship to trying to make us an ICB trauma-informed ICB, for want of a better word. What we'll try to do is I'll get the team, if that's okay with Alison and Emma, to have a look at some of the questions and maybe pop some answers down, and maybe we could send those out to people that have come. Well, we can look if there's a few, get the ones with the most likes or something. We can have a go at that because we didn't have the question and answer session, so apologies for that. But it's really important to listen to obviously the presentations. We will send those out, the slides out to people, so bear with us on that. We'll also send a link for the annual report, but you can hear the recordings again on our YouTube channel. But again, we'll send all those links out. I don't want to take us any more time than we have to, just to say thank you sincerely for all your time being at the conference today. I appreciate how difficult it is to get a whole Monday morning out, any morning, but certainly Monday morning when we have got an NHS-like week that is going to be particularly difficult. So thank you for your time. Apologies if we didn't get to all the questions. As I say, we'll try our best to get those frequently liked ones we responded to. Thank you all our speakers, some fantastic, just all fantastic, some fantastic examples there of work, and also very powerful, and still a lot of work to do across the board, if not following Sir Michael's presentation. But I just want to take 1 minute just to say thank you to Emily, Kelly, Alison, particularly. These conferences don't just happen. To get us all in the same room, even on MST, is no mean feat, but to get the speakers that we have is no mean feat. So thank you sincerely, Emily, Kelly and the team. And thanks to JJ Media for keeping us on. Just booted me out a second ago, which I was panicking, but I got back in. I think that was my broadband. Please have a look at our annual report. Please let us have your feedback. Please let us have any suggestions for next year. Thanks to Brent, thanks to everybody. Please stay safe out there, and thank you very much. And we'll draw it to a close. Thank you.
Very clear.
Are we off air, Jonathan?
Not yet.
Can we just